And can you see my screen? Can you see that I'm having?
Yes, yes, we can
Yes.
see.
Okay.
Yes,
Thank
so the screen.
you. Okay. I was deciding what we should do today, and based on information that I've been receiving from weak areas of people that have been taking their Nclex recently. There are so many points, but one of them is infection control. So a very brief review of infection control and some questions to practice. This is the plan for today. Um, I I really recommend you to go to the Center for Disease Control um, uh, .gov, okay, uh, and find all the isolation guidelines that that you can find there. Okay, those isolation guidelines um, are the ones that are used by Nclex, okay, to do their questions. So it's a document that you find in the Center for Disease Control that has in alpha order. It's a big document, has all the information that you need. But I think that the most important is that they have in alpha order the type of precautions of different diseases. And for example, in this moment, I'm showing the diseases that start with A, and you have that anthrax, pulmonary anthrax, and cutaneous anthrax, and any form of anthrax is a standard. And that's a question in English, okay? But infection control is anthrax, and you need to answer is standard. So when you start studying and you find something that brings you doubt, please go to the Center for Disease Control.gov and find the publication that they have there, the guideline for isolation precautions. And this is the most important document to be based. Remember that in infection control, they are going to ask you about the chain of infection. You need to be able to understand the chain of infection. Just a moment, guys. I'm going to change my way of presentation so I'm more comfortable with current slide. Okay, we're done with drawing. So remember that in the chain of infection, it's very easy. You don't need to memorize that. You have here an a bug, a stuff that is very bad, no, it's very bad, and is able to produce a disease in a human, in a human. So this is an infection when this bug can, reach, can from here go to here, producing disease. So the first link of the chain, okay, is the infectious agent is going to be written. And then you need to identify, okay, the first element necessary to have an infection is the infection agent. And the last link is the human that can catch the infection. But this human need to be susceptible. And this human is called the host. So the susceptible host is the last link. So it's the first that you construct or you build in your mind the two links that are in the extreme. So the next link is, where is this bug living? So it need to be living someplace. As I would say, even under a bridge, but need to be living someplace, Could be homeless, but need to be living someplace. But usually bugs live in other people, in animals, in the water, in the soil. So there is an environment where the bug is living. and it is called the reservoir, of the agent. So the reservoir is the place where the bug is living, and it's called reservoir. The next link is how this bug is leaving, okay, the reservoir to reach the human, and it is called portal of exit. So need to be performed. You live from exit, not from entrance. So is a portal of exit. The following link. Once the bug who was living in the reservoir leave the reservoir through the portal of exit, need to travel to the human. And this is called the mode of transmission, which is very important. The mode, okay, of transmission, okay? So mode of transmission could be through the air, which are, by the way, the most infectious diseases, the diseases that are, caught through the air are very contagious. Could be through the contact with fomite, could be through sexual activity, could be drinking contaminated water. So there is a mode of transmission that is important to know, because knowing the mode of transmission, then we can break this chain. Understand that any link of the chain that you can break interrupt the transmission of the disease. You can kill the bug, very difficult. It's very difficult to kill all the bugs. You can sanitize or eliminate the reservoir, the place where the bug is living. When in the first world countries build those plants for treatment of the water that is supplied to the population, and then this water is healthy, is clean, then a lot of diseases are eliminated. So all those waterborne diseases in which the reservoir is the water are eliminated with this intervention. When they when they pick all the stray dogs that in the past used to be in the streets, many decades or in the last century, then they eliminate a disease called rabies from being common, So it's the way. There are ways of controlling the portal of exit. When you request people to wear masks in diseases that are airborne or droplets, you are preventing the transmission of the disease because you are blocking the portal of exit. If you know that the way of transmitting MRSA in the hospital is through hands that were contaminated with the MRSA in the previous patient, and then washing the hands, you prevent the transmission of MRSA to the next patient. Knowing this mode of transmission, you break this link. The next link is the portal of entry. The portal of entry. So portal of entry. So there is a door to leave and a door to enter. Obviously, is the portal of entry of the human. The portal of entry more commons are the mouth, the nose, the eyes. Also, the genitals and the anus are portal of entry, very common. Why are so common those structures, portal of entry? Because those structures have a mucosa. One thing is skin, and another is mucosa. Mucosa is like the skin, okay, quotation mark, skin that is inside the mouth, the nose, covering the eyes, the anus, and the genitals. No, this kind of epithelium is not strong enough as to prevent the penetration of many viruses, bacteria, funguses, etc. That's why those portals of entry need to be cared a lot. And when you wear face mask, goggles, face shield, etc., you are mainly protecting your portal of entry. Okay, and of course, the last element is the susceptible host. How they ask more frequently the knowledge of this chain of infection in a question that place in order the links, the elements of the chain of infection. It's a very common question in English, in which you have the elements in this order, in disorganized, and then you need to move to the right in an organized way. As you notice, okay, you have your microphone open. Apart that you are not paying any attention, so obviously while you are connected, you're not paying attention, because I don't see the reason of connecting you're not paying attention. What is the reason of wasting? Okay? There is no attendance taken here. This is not mandatory. It's just the strong desire to pass the anchors, the one that should move you to be here connected. But apart of that, you are disturbing the meeting. Okay. Yes, Vaccine es pesado. Yes, so this is the order of organizing that, and this is the way that can be tested. What else can be tested? Okay, for example, they say when you give a vaccination, in which link of the chains are you working? Vaccination, of course, if you are thinking, are going to work in the susceptible host. A susceptible host become non-susceptible when receive a vaccine. This is the idea of the vaccine giving immunity, no? So obviously, they can ask you, okay, hand washing, mode of transmission. Why? Because the transmission of many diseases is through the dirty hands of the medical personnel. Okay, so as I said before, when they use prophylactic antibiotics in surgery, okay, what are they attacking? The susceptible host are killing the susceptible host? No. Who is killed with the antibiotic? The infectious agent. You know, when they eliminate stray dogs, when they let's see, they create what is called the herd immunity. You probably already know what is herd immunity. Herd immunity is when an important proportion of the population is immune either because it has already suffered the disease or is vaccinated. This portion that is not immune, this part of the population that is not immune because it has not been vaccinated, is not immune, is protected. Why? Because the disease is not circulating. Why is not circulating? Because everybody is immune. The majority is immune. So it is said that when a percentage of the population is already immune, is the people that are not immune are protected. No? And so, for example, this herd immunity could be a way of eliminating the reservoir of the coronavirus. The reservoir of the coronavirus is the humans. Okay, we are the reservoir of the coronavirus. I have the coronavirus and I pass the coronavirus to you. So I am the reservoir of the coronavirus. If coronavirus live in humans, okay, and we eliminate humans from the planet, there is no more coronavirus. Why? Because there is no reservoir, but also there is no susceptible host. Okay, but the reservoir of the coronavirus is the human. It is said that when an important percentage of the population is properly vaccinated and or immune because survive the disease, it is possible to stop, okay, the epidemic. So this is the concept of herd immunity, okay? And herd is like a group of animals, no? And yes, it's difficult to convince animals to have a herd immunity. Portal of exit, okay, when you ask a person that is coughing and has TB to wear a regular surgical mask, you know, is an example, etc., etc. Okay, so please have in mind this chain of infection because I so frequently tested in Nclex and has not any difficulty. Is there any doubt or question about the chain of infection? Can we move?
No.
Okay. Another topic that is not necessarily related with this, but is related with infectious diseases and epidemiology that I think anchors that some of us have not clear are these concepts, incidence and prevalences. Those concepts are tested in Nclex, and I want you to understand what is that because nurses need to use those terms properly. Incidents are new cases, new cases. Prevalence is the accumulation of cases, the addition a long time of cases. Let me explain this a little better. Suppose that we are talking about coronavirus. Okay, coronavirus. Let me change to black. Coronavirus. Okay, coronavirus. It is a disease that is very infectious, is very contagious, and a lot of people catches the disease. So in a moment, let's see, in one day, day X today, there is a lot of people that catch the disease. A lot of people that catch the disease. So a very high number of new cases. The outcome of coronavirus are only two. Or you cure and you survive, or you die. This is common for many acute diseases, for the flu, for pneumonia, for meningitis. Generally for acute infectious diseases, you have two outcomes. Okay, you survive, okay, and you cure, you eliminate the disease. So you cure, okay, or you die, okay, or you die. Those are the two outcomes of the coronavirus. You don't continue suffering of coronavirus for the rest of your life. Yes. So what you are going to have after a while, you are going to have that the people that have coronavirus, don't have coronavirus anymore because either they cure or they died. Okay, they died. Okay, and this is a disease with a very high incidence because in one day you have many new cases. The coronavirus has high incidence, but the prevalence is the number of cases that accumulates along the time of a disease, because cases of coronavirus don't accumulate. The prevalence, okay, is very low. Let's talk about diabetes mellitus. Diabetes mellitus is diabetes mellitus type 2. That is the most common. Today in Miami, probably uh, all the hospitals, all the doctors from Miami diagnose in total, let's see, 100 new diabetic clients today, maybe less. So compared with the thousands of people that are reported daily with coronavirus, the incidence or new cases of diabetes is low. So diabetes mellitus have a low incidence, okay, a low incidence. A low incidence. You are clear. But what happens with diabetes? You don't cure of diabetes. So there is no cure for the diabetes. You continue being diabetic the rest of your life. And you don't die. You don't die quickly of diabetes. So what happens that every day they are diagnosed 50, 60 cases, new cases, low incidence, but they are added, okay, along the time to the statistic. So diabetes mellitus has a very high prevalence because along the time, every day, new cases are added. Even there are few new cases, they don't die, they don't cure. and it accumulates. So the prevalence is high. And this is the way that is tested in a practical way. They ask you, meningitis, how is the prevalence, how is the incidence? Flu, I remember that the flu is one of the most common, okay? Flu is very similar to coronavirus, yes? Are diseases with very high incidence, but low prevalence. Hypertension, similar to diabetes, okay? Relatively low incidence, but very high prevalence. So it is a terminology that you need to be able to manage as a nurse. And that's it. I just wanted to know that because I saw this question many times in English. It's clear. Can I move or I need to repeat the explanation? No doubt? Okay, so moving on. No question, no? Okay. Remember that everybody, independently of the disease, infectious or not infectious, is a standard precaution. So everybody is a standard precaution. You can add to the standard precaution other isolation precaution like contact or droplets or airborne. But everybody is a standard precaution. So it's the first concept. It is the way of avoiding infectious diseases that are not yet diagnosed because people can be carrying HIV, hepatitis B, hepatitis C, syphilis, and many other infectious diseases, can be incubating coronavirus, can be incubating meningitis, you know? And if we don't know that the person has the infection because has not yet presenting symptoms of is a disease that it can be carried without symptoms, then we can catch the disease or we can pass the disease to others. So that's the reason of the standard precaution. So have this concept clear. And in a standard precaution, it is mandatory that every time that you deal with a client, you need to wash your hands before and after. And this is for everybody, diabetic, TB, whatever. You need to add gloves for standard only if you are touching one mucosa. Trying to keep this microphone, okay, muted. Mucosa. So we talk about eyes, nose, mouth, genitals, anus. So if you are administering suppository, if you are introducing, qué sé yo, a nasogastric tube, if you are administering eye drops, you are doing mouth cares, etc., you anticipate you are going to be touching mucosa and you need to wear gloves. 2, when you are going to manipulate body fluids, you are going to draw blood, you are going to make an injection, a intramuscular shot, but you know that blood can come from the shot or interstitial fluid. You are going to be dealing with urine, feces, cerebrospinal fluid, whatever, and then you need to use gloves each time. Blood, when you are going to hang blood in transfusion, you are manipulating body fluids, you need to use gloves. So if you touch mucosa or if you manipulate body fluids. And third, if you're touching, open skin. So if you are doing any assessment of a rash, this is open skin. Any rash is open skin. So you consider any rash open skin. But I don't see the skin broken. If there is a rash, consider it open skin. If you have a wound, if you are measuring a wound, etc., you need, of course, to use gloves. So hand washing, but in some situations you add gloves. You don't add gloves if you are touching intact skin. If you're touching intact skin, like for example, when you auscultate a client, like for example, when you check blood pressure or when you take the radial pulse, you don't wear gloves. If you wear gloves, the question is answered wrongly, and you lose the question. So you only put on gloves when you are going to touch mucosa, touch body fluids, touch open skin. In the majority of the cases, the gloves that you are going to be using are clean gloves. The most important moment in which you need to use sterile gloves is if you are going to suction a tracheostomy or endotracheal tube, because you are going to hold in your hand, with your hand, at least with your dominant hand, you are going to be holding the sterile catheter that is introduced inside the sterile tracheostomy tube that is inside the sterile trachea. So because for trach suction, you need to touch this catheter, you need to touch the catheter with a sterile glove. Second, when you are introducing a Foley catheter are going to be held, are going to be touched by your dominant hand. Yes, and for that reason, to touch the sterile Foley catheter that is going to be introduced in the sterile urethra and in the sterile urinary bladder need to be touched with sterile gloves. Simple. Notice that I always said dominant hands, because in both in the trach suction and care, no? Trach suction and care, and in traditional Foley, you have one hand sterile, but the other hand is not sterile. The hand that is separating the labia majora of the woman, or holding the penis of a man for a Foley, this hand is not considered sterile. The other hands in suction, that is holding the oxygens and removing the oxygens, and and touching the tubing that go to the suction, the wall suction, is not sterile. The one that is sterile is the dominant hand. Everything, those details have been tested in Nclex because it is basic nursing. Are you understanding until now what I'm saying about sterile globe? No?
Yes.
If you have doubt, ask questions. Okay? And in those situations, again, when you are going to be touching a wound, when you are going to be touching a wound, you need to use sterile gloves. Wounds are considered sterile, even they are infected, but you don't want to bring another bacteria. So you need to wear sterile gloves to do the wound care. Also, you need to use sterile gloves when you are manipulating central catheters. Central catheters requires one sterile gloves. So those are the most important situation in which you need mandatory to use sterile gloves. But in the majority of other cases, okay, clean gloves are okay. For example, to introduce a nasogastric tube, you don't need sterile gloves. For example, to get an IV, a peripheral venous access device, those catheters that you were taught to introduce in the forearm of patient, the small catheter, because you don't touch the skin and you don't touch the catheter, you can wear clean gloves because there is no need of sterile gloves. Why is important this? Because Nclex give importance to the economy. A sterile glove is expensive, okay? A pair of sterile gloves is going to cost more than $1. Yeah. While a clean gloves is costing only cents. Anchors give importance to that. If you don't give importance to economics, because this is not your money, take care, because you can fail a question because this reason. So understand that saving unnecessary expensive, okay, is important in Nclex. So we use sterile gloves only when it is necessary, okay? So talking about when we use gloves, okay? And the last and standard precaution is that if we anticipate that the procedure that we are doing could produce splash, okay? And irrigations, it produces splash. Enemas. There is a microphone that is open, and I'm hearing myself. Enemas, intrusion in nasogastric tube could produce a splash. Suctioning of a trach produces a splash. So you need to anticipate more or less situations where you can have a splash. Then you need to protect your glove, your clothing, your scrub, because then if there is a splash with bacteria, and then you go to the next room with this dirty scrub, you pass the infection to the next client. And also for a splash, you need to protect your eyes, nose, and mouth. So you need to use a facial or a combination of impervious mask, facial mask, and goggles to protect you. So this is the basic of standard precaution. And everybody is standard precaution. The most common mistake in standard precaution is people wearing gloves because they are going to take the blood pressure of a patient with HIV or hepatitis B. So you don't need to wear gloves to touch the skin, the intact skin of a client with hepatitis B or HIV, because those diseases are only standard precaution. It's very different if you're going to touch, if you are going to measure the blood pressure, or if you are going to count the heart rate, the radial pulse of a client with scabies, with MRSA, then you need mandatory to wear gloves. But it is because those diseases are contact precaution, and the contact precaution requires mandatorily the use of clean gloves, not sterile gloves, clean gloves. Okay, so I'm going to repeat again, so it's very solid in everybody. Remember, I need to give a message for everybody. In a standard precaution, when the client is only standard precaution, and the majority of the diseases are only standard precaution, you don't wear gloves if you're touching the intact skin, like to check the pulse or the blood pressure. And you need to know that HIV, hepatitis B, and hepatitis C, and many others, but these three are standard precaution. So you don't need to wear gloves to check the pulse of a patient with HIV, because you will never get HIV. You'll never catch HIV checking the radial pulse of a client, touching his or her skin without gloves. You need to wash your hands, as I said, before and after, but there is no need to wear gloves. So it is one of the mistakes that I see more frequently in Nclex. The other is this, if you know when the gloves need to be sterile, when the gloves need to be clean. And the last, but not the least, is developing the knowledge of all the diseases that are only standard precaution. There are a bunch of diseases that are only standard precaution. Infectious diseases, of course, diseases that are not infectious, I say diabetes, hypertension, are standard precaution. Why those diseases are standard precaution? Just in case the client, a part of the hypertension or the diabetes, is carrying an infection that is not yet diagnosed. But there are infectious diseases like HIV, hepatitis B, hepatitis C that are only standard precaution. Doesn't require more precaution, a part of the standard precaution, okay? And there are many. You have the anthrax, you have the Legionnaire disease, you have the pneumocystis jirovecii pneumonia, you have many diarrheas, you have many diseases that are ultimolita, for example, diseases that are internal, and doesn't spread out, okay, like osteomyelitis, like endocarditis, like toxic shock syndrome, okay? Those are diseases that you need to know are standard precaution. It's much, much easier to learn the diseases that are contact, droplets, and airborne because are less. And if you know the disease that is contact, droplets, and airborne, then you know, oh, those diseases are a standard and contact, a standard and droplet, a standard and airborne. So they are not only standard, are standard and droplet, standard and contact. So are less diseases, and it's easier to learn those diseases because it's practically impossible memorizing all the diseases that are only standard precaution. Make sense? So when you have a disease X that you know, but you really don't know exactly if it's only standard precaution or if it is a tier 2 infection control, is if you know which one are contact, which one are droplet, which one are airborne, then it's easier to say, oh no, this is not contact, this is not airborne, this is not droplet, it's only standard precaution. This is the best way of learning that, okay? The contact precautions, okay, so we said all diseases, infectious or not infectious, are standard precaution, but sometimes apart, added, plus the standard precaution, sometimes some infectious diseases or contagious diseases require extra precaution. And those extra precautions, this second level of precaution can be contact, droplet, or airborne, and those extra precautions are added to the standard. This contact, droplet, and airborne require isolation. Isolation means that the patient needs to be alone in the room. Yes, contact, droplet, and airborne diseases require the patient to be alone, only alone in the room. Diseases that are only standard, diseases that are only standard, that don't require this tier 2 level of isolation, this added level of isolation, contact, droplet, and airborne. Yes? Don't need isolation. It means that they can be with other clients, even in the same room. So it's important to understand that these infectious diseases, yeah, contagious diseases, but they are only standard precaution, do not require isolation, and the patient can be in a room together with other different clients. It is called cohorting. So a patient with HIV is only a standard precaution. If it is hospitalized, doesn't need to be alone in a room. No. You can put this client in a room in his bed, and you put myself that have no HIV, has a, I don't know, myocardial infarction in the other bed, okay, but in the same room. There is no need of placing the HIV in isolation. And when they go to the cafeteria or to the dining room, they can sit in the table at my side. You understand? So diseases that are infectious diseases, because HIV is an infectious disease, it's a contagious disease, but a type of transmission that is controlled only with standard precaution, there is no need of isolation and can be cohorted with other clients, infectious or not infectious, as far as only standard. So only standard can be cohorted with another only standard. And hepatitis B, that is only standard, can be cohorted with diabetes, that is only standard. Example, make sense? Or a hepatitis B can be cohorted in the same room with HIV, that are only standard. But if the client has an infectious disease that requires contact, droplets, or airborne, cannot be cohorted in the same room with other clients. Probably you heard or studied that if it is demonstrated that you have two clients that have the same disease that require, for example, contact precaution or droplet precaution or airborne precaution, and is demonstrated that have the same bug, the same, let's see, bacteria, and the bacteria have the same antibiotic sensitivity, okay, susceptibility, can be cohorted in isolation. But the probabilities that this theoretical scenario occurs is practically impossible. Because if you have a patient with meningitis, and you know what is meningitis, have another client with meningitis, and you know what is another client with meningitis, and both are arriving in this moment to the ER and need to be assigned to a room, I cannot cohort those two meningitis. Because this meningitis can be meningitis by pneumococcus, and this meningitis could be meningitis by meningococcus. Yes? And suppose that both are, I don't know, pneumococcus meningitis or meningococcus meningitis. Yes, meningococcal meningitis. Okay, maybe this is resistant to cephalosporin, and this is not resistant to cephalosporin because bugs behave differently. The strains of the bugs, of the bacteria, behave differently in presence of the antibiotic. I cannot cohort those clients with different sensitivity. What is the probability that I have the knowledge that two meningitis arriving to the ER come already with the culture and the sensitivity and have exactly the same? Practically zero. So forget, in Nclex, there is no cohorting unless in Nclex there is no cohorting unless it is only a disease infectious disease, only a standard precaution. Okay? So there is no cohorting in contact, there is no cohorting in droplet, there is no cohorting in airborne because it's not practical, it's not realistic. Okay? The only diseases that can be cohorted in Nclex, okay? The only disease that can be cohorted in Nclex and is isolation is bronchiolitis. The RSV, which is the virus that produces the bronchiolitis, okay? You should know at this level what is bronchiolitis. It's a disease of small children that is infectious, is viral, is highly contagious, and requires isolation because it's highly contagious if the patient is hospitalized. But the virus is constant. It's always the same virus, the same strain, and there is no need of susceptibility because it's not treated with antibiotics, neither with antibiotics nor with antiviral medication. It's treated symptomatically. So RSV is the only example that in real life in USA, in America, in real life and in Nclex, it's possible to have a disease that requires isolation, but then you receive more than one case in the same day, and you can cohort in the same room. If you didn't understand my explanation, you only can cohort standard precautions.
Profe, can you put the slide, the previous slide for 1 second? No, the droplet. Thank you.
Okay. I will publish this because I was trying to summarize this. So please understand that for cohorting, only pure standard infectious diseases. Okay? And the only disease in Nclex that requires isolation that can be cohorted 2 or more clients in the same room is RSV bronchiolitis. Period. Okay, contact precaution. You need to know that the patient must be alone in the room. 2, is Any room is not a special room, but patients need to be alone in the room. 2, the door of the room is left open. 3, in this room, anything that touches the client cannot leave the room. The stethoscope, the blood pressure cuff, whatever, yeah, the remote of the TV, whatever, cannot leave the room. Okay, so this is what isolates the clients in contact precaution. The patient is in the room all the time. Any person entering the room need to be wearing gowns and gloves, but no mask, please, no mask, okay? Gowns and gloves for anything. If you are entering to say hello, or if you are entering to bring the food, you need to wear gowns and gloves, and you need to remove the gowns and gloves before leaving the room. That's it. And it's very important that the linen need to be taken out of the room with double bag. Okay, bag. Okay, it means that if this is the room, it is the door of the room. Yes, it is the door of the room. This is the hole, and in the room, inside the room, okay, is the client. No, inside the room is the client. No? The client is in the bed. Yeah, the client, and you are the nurse, and you or the CNA, and you remove the linen of this client in contact, you are going to be standing inside the room, but in the other side of the door, okay, standing here with your back of linen, okay, your back of linen close. This is the back of linen here, not inside the room. No, it's difficult to draw. Another person, another nurse or CNA is outside the room with gloves, okay, holding an open bag outside. So this other nurse is with a bag, an open bag, no, open bag. It is a bag that is open, yes? And then this bag, let's put the bag red, this bag that is closed with the linen inside, but is contaminated outside, is going to be placed inside this bag that the other nurse is keeping open. And then this nurse is going to close the bag and send that to the laundry. This way, the contaminated bag, because this bag was inside the room and is contaminated outside the bag, is going to be inside another bag, vamos a poner azul, okay, another bag, okay, that is isolating, okay, this contaminated bag, okay, double bag technique is called, okay, and it's tested in Nclex. That's why I'm telling you, because I see this question, okay. This is a technique very commonly used. Even when you remove your globes, you can keep inside the globe, both globes that you remove, okay, something very dirty, okay? And ¿qué dije yo? Sí, that's it. If the clients need to go out, because the most common cause of isolation, the most common, 90% of the isolation in contact is because the patient has a wound contaminated with a bacteria that is a superbug, is a super multi-resistant drug organism. So MRSA and similar, no? And for that reason, the wound need to be covered with an impervious, with an non-porous dressing for transportation to X-ray, etc. And then the dressing is going to be removed when coming back. It's clear? Very well. The challenge is memorizing all the diseases that are contact precaution. And the way that I memorize that, I say skin, diarrhea, and bronchiolitis. This is the way that I memorize. I say skin, infections in the skin, diarrheas, certain diarrheas, especially the patient is incontinent, yes, and RSV, bronchiolitis. So I have 3: skin, diarrheas, and RSV. The most challenging for my brain is RSV bronchiolitis, because it's a disease that I know produces cough, is respiratory, is in the bronchi, and my logic says, oh, it should be droplets, but it is not, it's contact. Science says that it is contact. So I need to wear gowns and gloves instead of a mask for the prevention of this disease. If I don't remember that, then I deserve failing the exam. Yes, so it is very important. There is a warning here that please remember that this disease is contact, is not droplet, even if your logic could say that the opposite. The skin, I always think that the most common reason of placing a client in isolation is a wound in the skin that frequently are surgical wounds that are infected with bacteria acquired in the hospital that are super resistant to the antibiotics. And then I have what I call la sopa letra. MRSA, BRSA, CRE, BRE. So can be mentioned any one of those bulbs that are represented with acronyms. Methicillin resistant Staphylococcus aureus, vancomycin resistant Staphylococcus aureus, carbapenem resistant Enterococcus, vancomycin resistant Enterococcus. You don't care what means those acronyms, but you need to recognize in the test, in the question, that when you see those acronyms are super bacteria that must be isolated in a room because are not responding to the antibiotics. And for that reason, you don't want this bacteria, this horrible bacteria, moving to another room, please. It's logic. And that's why it's the most common reason for isolation in contact. And the way of passing this bacteria is through objects, hands, gown, scrubs, stethoscopes, contaminated with bacteria that leave the room contaminated. Yes. So for that reason, entering this room, you need to wear gowns and gloves, a part of washing your hands. And you need to remove this gown and glove before leaving the room because the bacteria is in the objects, in the fomites, okay? You know that coronavirus is contact. A part of airborne is contact. You know that coronavirus survives for many hours, some say days, in a surface, in the bottom of the elevator, in, I don't know, in a cardboard, in metal surfaces, in a chair, in a table. Same happens with flu, influenza. Yeah. And also the common cold virus. Okay, those are stuff that survive in the surfaces for a long time. That's why when you touch, even it had been many hours later, okay, you touch something, you can get the bacteria, the virus there. So those are conditions that requires contact precaution. Frequently, those infections in the wounds and soft tissues are associated with impetigo, which is an infection of the skin, abscesses, and etc. I'll discuss later because what's in English that there is a disease that is droplets called diphtheria. You don't know what is diphtheria because your mother and your father or maybe your grandparents vaccinated you with a vaccine called DTaP that is very old. Is a shot given to you when you were a child. So you are immune. You are not susceptible to diphtheria. But diphtheria is a horrible disease that is mainly localized in the throat and can kill. Yes, but sometimes it's in the skin. When the diphtheria is in the skin, it's called cutaneous diphtheria, is contact, is not droplet. So pharyngeal or laryngeal diphtheria is droplets, which is a different, it's just mask. But if it is cutaneous diphtheria, it is contact, which is gowns and gloves. If it is flu, influenza, uh, is droplet. Influenza is droplet, but you need to add contact. If it is common cold, generally is produced by adenovirus, is droplet, but you need to add contact. Yes. Um, so it's important. Even in coronavirus, which is airborne, yes, you need to add contact. you need to add contact. Even chickenpox, varicella, that is airborne, okay? You need to add contact because there is also need. So some diseases are standard, comma, contact, comma, and airborne, for example, or standard, droplets, and contact, okay? And sorry, we need to know that. It's life or death for nurses to avoid getting the infections and taking the infection to other clients and to their homes. Okay, so here I made a summary. I will share that with you. I think that anybody that has not been my student, no, because my students have all those slides, need to know that for English. Herpes. There are two types of herpes: herpes simple and herpes zoster. They're different. They're different diseases. The herpes simple is the one that produces the cold sores in the lip, and the genital herpes. Very common, very common. Both are very common. Sometimes you have the need of hospitalizing a client with this herpes simplex, then you need to isolate the client because it's highly contagious. Herpes zoster, also called as shingles, is also requiring contact precaution because the majority of the clients with shingles are not hospitalized. What is recommended is you stay in your room, have all time covered, okay, the lesion of the shingles, and don't allow anybody else in the house to touch you, especially if this anybody has never suffered of varicella previously, okay, because shingles can pass varicella to other people. Conjunctivitis, the hemorrhagic conjunctivitis required, okay, contact precaution. Scabies and pediculosis required, okay, contact precaution for 24 hours only. It's interesting that there are many infectious control measurements that are discontinued after 24 hours, and you need to know it's tested. So in the case of scabies, okay, and pediculosis, after administering the medication, the permethrin, the patient, after 24 hours after administering the permethrin, the patient doesn't need to be in contact precautions anymore. The diarrhea that requires contact precaution basically is the Clostridium Difficile, the C. diff diarrhea. Also, rotavirus and norovirus are two viruses that produce diarrhea in children and in nursing homes, are very contagious, requires contact precaution. The other diarrheas, for example, E. coli, Salmonella, Shigella, those other diarrheas that people can have, bacterial diarrheas, require contact only if the client is incontinent, because majority of the clients are continent, and you know what is continence, no? Then there is no need of isolation in contact precaution. Okay, so that's why I say any other infectious diarrhea is contact if the client is incontinent, there is incontinence. And don't forget the RSV. I cannot introduce in your brain this. This is introduced only when you repeat. Repetition is the only way of developing long-term memory in something that cannot be understood, just memorized. You know, the other can be understood, but this must be memorized, and you need to make the effort of incorporating that to your long-term memory. It's important for your English. The droplet precautions are diseases that are transmitted through the air, but big drops that fall at 3 feet of distance of the emissor. And only the patient that is in droplet precaution must be alone in a room, need to be alone in a room, but the door can be left open. And any person entering this room must be wearing a regular surgical mask, the same that is used by the surgeon. If the client is the one that is leaving the room for a procedure, X-ray, whatever, the client is the one that is going to be wearing the mask, not the rest of the hospital. Yes, but when the client is in his or her isolation room, the client doesn't need to wear the mask. It's the nurse, the physician, the CNA, the housekeeper, the one that is wearing the mask to enter the room. That's it. Nothing else is needed, okay? Unless the standard precaution requires something else. And no, it's very easy. The only thing that you need to memorize all the diseases that are droplets. For this is very useful. I found, even if I don't like mnemonics, okay, I prefer to memorize. I prefer to understand and then memorize. Mnemonics are, I found this mnemonic very useful. So the S of Spider-Man, okay, relates with strep throat. Strep throat is one of the diseases that once you start the penicillin, 24 hours later, you are not contagious anymore. Scarlet fever is related with strep throat. Scarlet fever is an strep throat that complicates producing scarlet fever. Scarlet fever has a lot of fever, but before being a scarlet fever, have an strep throat. Scarlet fever starts as an strep throat, and then appears the rash and the strawberry tongue, etc., etc. P stands for pneumonia, but not all pneumonia. And pertussis, which is the same as whooping cough. They are the two most important. So now you are going to memorize that the pneumonia that requires a droplet is Streptococcus, Mycoplasma, and plague. Please believe me, I've been paying attention CDC, infection control, and what Nclex is testing. And you need to know that the pneumonia that requires droplets are not all the pneumonia. Only Streptococcus pneumonia, Mycoplasma, and plague. Okay. The mycoplasma is what it is a bug that produces what is called the walking pneumonia. Plague is something that we studied that was very common in the Middle Age and came in epidemics. Okay, the Black Death, the bubonic, okay, plague, etc. But it is still is present, okay, and requires droplets. And Streptococcus pneumonias, yeah, those are the one that requires droplets. So if you have, for example, Legionnaire pneumonia, if you have anthrax pneumonia, viral pneumonia, Klebsiella pneumonia, gram-negative pneumonia, ¿cuál era otra que me falta? La pneumocystis jirovecii pneumonia. Those are standard. Those are not droplets. And you need to know that. It's tested. Pertussis whooping cough. Okay, remember that it is covered by the DTaP, the same vaccine that covers the diphtheria. Parvovirus B19, I put that there because it's only also P, is the virus that produces the fifth disease. And yes, it is, I don't think it's going to be tested, never seen that tested, but it's just in case. Okay, I is influenza, but please, influenza add contact. This is diphtheria, but the pharyngeal or laryngeal diphtheria. The cutaneous diphtheria is only contact. E, epiglottitis. R, rubella. M, meningitis and mumps. Meningitis again. Meningitis refers to bacterial meningitis, no? Because viral meningitis is the standard. And again, the 24 hours rule apply. After 24 hours of antibiotics, there is no need of more isolation. And AN is the adenovirus. Adenovirus is a group of viruses that produce mainly the common cold. Common colds are more common than influenza. So the one that you have 3-4 times per year, okay, is adenovirus probably, yeah, and also requires contact. So both flu, that is rare and has a vaccine, and common cold that has no vaccine and is more common requires droplets and contact. And again, you need to memorize that.
Professor, I have a question.
Sure.
You can cohort a strep throat with a scarlet fever?
Nope. Because you can have different, okay, different strains and different resistances there. So is not recommended cohorting unless you have proof that the culture and sensitivity is the same exactly. So You cannot know if this strep throat, this client with a strep throat, and this client with scarlet fever, the streptococcus has the same sensitivity. This is what the CDC says about cohorting. You have a culture. It's the same bacteria, the same DNA bacteria, the same sensitivity are treated, but they say, okay, maybe it can be cohorted. But this is a requirement, need to have the same sensitivity. Do you understand? Both are produced by streptococcus, okay, group B, beta hemolytic group A, but you need to know if it is the same sensitivity. Yes.
I have a question and doubt. For example, this patient that all of them are dropper precaution, but the nurse need to take the vital sign will be closer than 3 feet from the patient. Need to be. You only gonna use a surgical mask. You don't need to use a
only surgical mask. If you are at a higher distance, even you don't need to use the surgical mask. But because all the nursing care is at less than 3 feet, okay? Because what is recommended to keep the distance, the distancing is 6 feet, okay? Because you cannot measure exactly 3 feet because, it's too exact. You keep 6 feet of distance, and you know that from the coronavirus. But nursing care is with regular surgical mask.
Okay.
No gown, no gloves. So this is what has been by protocol established, independently of what your logic wants to tell you or what you do when you practice if you work in the field. Remember that you answer, if you have problems with that, then you need to go to the first statement that I called when I started the review. Go to the Center for Disease, CDC, control, GOV, and look for the document of infection control that I show. And then what says there is what you answer in the Nclex. Remember that you go to the Nclex to please the person who wrote the question for Nclex. That, by the way, is a very high-level person. There are doctors, epidemiologists, pharmacists, etc., writing the Nclex question, and the question are discussed, etc. You go to the Nclex not to teach them. You go to Nclex to please them. You go to Nclex to pass the Nclex, and you don't pass the Nclex discussing with them. No, in my work I do this because there is a possibility. No. You go by the book. Remember that. Don't apply in Nclex your personal experiences of what you think. Trying to go in the question by the book, please,
Okay.
is an advice for Nclex. Don't try to do research in Nclex, to change policies in Nclex, because in this aspect, they are very strict.
Okay.
So memorize this way. Of course, if you have a patient with influenza or with pneumonia, and you are going to introduce a suppository, of course, you are going to wear gloves, but it is for standard, because remember,
that is a standard, yeah.
Exactly. This patient is droplet and standard, yeah? So this makes it more complicated because we never forget that these clients in droplets is also standard, no?
Yeah.
In the case of the influenza, because you need to add contact, then you need to wear gowns and gloves, a part of the regular surgical mask when you enter. That's why it's so important to know that influenza and adenovirus need to add contact. But then I assume that we are adding standard to all the 3 isolations, the 3 contact. It makes complex infection control. Thanks God, in Nclex, they are good. They don't make the question too complicated. But infection control is really, really, really complicated. Yeah, you are seeing why. No, you're seeing why. And they can, if they want to make a complicated question, can be complicated. And it is the case of the coronavirus, because coronavirus is a disease that is airborne. Previously was called droplets, but then was upgraded to airborne, and is also contact. It's not enough to use the N95 for preventing the coronavirus. If you are a nurse and you don't want to catch the coronavirus, the 100 coronavirus that are arriving to the ER and ICU, you need to wear the N95, okay, but it's not enough. You need to protect from head to toe from the contact. In the end, that's why coronavirus is so demanding in the PPEs. You know? And that's why in my country, I had 12 physicians, friends of mine, that died of coronavirus. Why? Because they don't have those PPEs there. You understand? 12 of my colleagues that I knew, friends of mine, okay, dead already of coronavirus. Okay, well, because they don't have PPE. Okay, but it is the break. Okay, so now let's go to airborne. Airborne, you know that is special because airborne is the most contagious, and in airborne the room must be special. Need to be an adapted room that should have an extractor of air that recreates a negative pressure in the room. And the door must be all time closed. Once we talk about closed door, anchors make questions related what implication has to have a client with an infection that requires to keep the room closed all time and to limit visits, etc. So it brings social isolation and depression. So have that in mind, because if you have this concept clear, you will be able to answer the question. So like, what element should you include in the care plan of a client with tuberculosis? And they say, okay, management of social isolation and depression. ¿Y por qué? Why? So now you understand why. Any person entering this room should be wearing a N95, but take care. Frequently in NCLEX, they don't say N95, they say the word respirator or particulate respirator, okay? Or highly efficient particulate respirator. So when you say the word respirator, it's the same as N95, yeah? En guerra avisada no mata soldado, okay? So this is a special mask that ultrafiltrate from outside to inside, and for that reason is what the nurse, physician, whoever that is entering the room, visitors, whoever, should be wearing. Yeah, it's interesting. There are two diseases. This is Nclex, guys. This is details for Nclex. Two diseases that confer permanent immunity in the people that suffer the diseases or were vaccinated. Measles and varicella. Measles and varicella are airborne, but people that suffer of measles, varicella, or are well vaccinated against measles and varicella, and have demonstrated immunity. How you demonstrate immunity? You draw the blood of the person and check how many antibodies have, okay? And they calculate titers, okay, concentration of the antibiotics. And usually they call that the titers, okay? Titers. If you have demonstrated immunity against measles or varicella, you don't wear the N95 to enter the room. There is no need of wearing the N95 to enter the room. Are we good? Okay, only standard, not N95. Of course, tuberculosis requires always N95 because nobody is immune to tuberculosis. Okay, very well. In the case that is the client, the one that is leaving the room, the client is not wearing N95, is wearing a regular surgical mask. What you don't want from the client is to emit, to throw through the nose and the mouth the bacteria or the virus. And surgical masks has been designed by the engineers that build that stuff to filter from inside to outside. Because when a surgeon is working in the open abdomen of a person, the important is that the bacteria of the nose and the mouth of the surgeon not going to the abdomen of the client. So those masks are more efficient filtering from inside to outside. That's why it's much, much better for a patient that is throwing through the nose and mouth bacteria or virus to use regular surgical mask instead of N95. N95 has been designed by those engineers to ultra filtrate from, but when you breathe in from outside to inside. That's why the nurse uses an N95 to filtrate from the air, has the bacteria to filtrate the air from outside to inside, but the patient, if need to wear a mask, should be a regular surgical mask that is more efficient filtering from inside to outside. That's the explanation, but need to be remembered. I think that if you have the explanation, it's easier to remember. And then again, is memorize, okay, what requires, okay, errors. Measles, chickenpox, and tuberculosis are the classical. Please, in chickenpox, you need to understand that those vesicles and this liquid contains the virus the same as the shingles. And for that reason, you need to add contact. Shingles is only contact. Varicella is airborne and contact. But you need to know there is a very rare type of shingles. In all my life, and I saw a lot of patients in my life, I only saw one case. It's called generalized or disseminated shingles. When you have chickenpox, as I had, then the virus stays living with you. And one day, especially when you grow older, the virus can grow again because it's living with you, but only can grow inside a nerve, hidden inside a nerve, producing
Video
this. Okay, producing the shingles. Okay, but if moi, that has the virus with me, suffer of immune suppression, AIDS, high doses of prednisone, immune suppressor, because they made a transplant on me, or high doses of chemotherapy. Now, this shingle that should be only here in one nerve disseminates in all my body. And then, because disseminate is also in my throat, and I breathe out my breath with the virus floating. So, what is generalized shingle? Another varicella, another chickenpox. Yes, for practical approach. That's why if there is generalized disseminated herpes zoster, which I repeat is a very rare condition in which the shingles appears in a person with immune suppression, severe immune suppression, and generalized, producing a second varicella. And of course, varicella is airborne, but it is not the regular shingles. The regular shingle, the one that you know, la culebrilla, it is only contact. Okay? And you need to know there is a condition called severe acute respiratory syndrome. This stuff is produced by the coronaviruses. In 2002, 20 years ago, okay, 20 years ago, appears in China, in Hong Kong, and in the east coast of China, an epidemic of pneumonia in young people, very contagious, and people dying. They investigated and they discovered that those pneumonias were produced by coronavirus. Was high mortality, terrible mortality. Sounds familiar? 22 years ago, 20 years ago, yeah, see? So this was the first time that coronavirus produced SARS. And thanks God, this virus, this strain of the coronavirus was less contagious. And after the epidemic extended a lot in Asia, stops. People developed herd immunity, started, isolations and control, and the epidemic stopped and never reached United States except a couple of imported cases. There were more cases in Canada because in Canada there are a lot of Chinese people. Okay, it is a virus that frequently is in animals and can pass to humans. The same happening with the HIV and many other viruses. Nothing new. Yeah. So at that time, it was described as severe acute respiratory syndrome, period, without last name. Now, in 2019, happened the same. And now the virus became more contagious. This strain was much more contagious. And because the travel was most generalized every day, then it spread all over the world. And you know the story. And people, again, developed severe inflammation in the lungs and they died like flies. Okay? People mueren como mosca. Yeah? And it is also called severe acute respiratory syndrome. So those people that you know that died of coronavirus, it died of this severe from the coronavirus, which is a cytokine storm called severe acute respiratory syndrome. But now to differentiate from that coronavirus, they call that SARS-CoV-1, and this is SARS-CoV-2. Okay, so the one that we have now is SARS-CoV coronavirus 2. Just in case you see this terminology and you don't understand, now you understand. Because I think a nurse should know this little history. Okay, nurses need to know the history of the diseases. Okay, so now there is a mnemonic that my chicken has TB and SARS. So my measles, chickenpox has generalized herpes zoster, TB and SARS. Okay, those are the. Let's see. It is a reproduction of an Nclex question. The nurse needs to assign a room to a 6-month child with bronchiolitis. Which room choice is the best? Okay, so you receive a baby with bronchiolitis. In which room you put this baby? Private room with negative air pressure, double room with a patient with droplet precaution, private room further from the nurse station, double room with a 4-month-old with RSV. What is the best answer?
D.
D as in David, because RSV and bronchiolitis is the same, and this is the only example in which you have what kind of infection control of bronchiolitis?
Contact.
So you can
D.
cohort
Yeah.
in contact isolation these two patients. So this is the only practical. To have the possibility of cohorting isolations, you need to have an epidemic. And until now with coronavirus, now coronavirus has the Omicron, que si el otro, there a new one coming, okay? But in the case of the bronchiolitis, it's very constant. That's why. And bronchiolitis comes every year in winter in epidemics in children. That's why there is a possibility of having 2 children, high possibility 2 children with the bronchiolitis, the same RSV, and you can cohort. It's the exception of the rule that I told you, that cohorting in isolation is practically impossible because it is required in good law, in good, infection control stuff, to have sensitivity of the bacteria, to be sure that there are not 2 different strains of bacteria, one resistant and the other susceptible to the antibiotics. Remember the order of donning and removing the PPE. You need to memorize. It's very easy. Use this that is in the PowerPoint. This is CDC. This is the one that used the Nclex. Okay. Okay. So donning is put on. Okay, and removing. Yeah. So put on first the gown, then the mask or respirator, then the goggles or shield, and the last the gloves. To remove first the gloves, then remove the goggle or shield, then the gown, and then the respirator. Okay, and wash your hands. Okay. That's it. This is what you need to know. It's important because they test a lot in Nclex if you know how to put on and how to remove the gloves if they are sterile. Okay, so or not practice that because it's tested in 100 different forms. If you know how to put on and remove the gloves, you won't have problems in those questions. Remember that always you need to wash your hands before, okay, doing that. And then when you have the sterile gloves, you'll see that they are the lower parts are folded, okay, making like a pocket, yes? And then you need to know that the first gloves that you are going to don is your dominant hand. Notice trying to put yourself in front of those gloves. So trying to turn yourself and put in front of the gloves, okay? So notice, okay, that this glove is, the majority of us are right-handed, no? Is the first that is going to be done because the right hand is the most commonly the dominant hand. But if you are left-handed, then you don first the left gloves. You understand that, no? So what they use, right or dominant? Dominant, to include los zurdos, to include the left-handed. Is clear? So first, the dominant hand, and second, the non-dominant hand. Remember that the dark part, so the dark yellow is sterile. The light or white is non-sterile. So you can just pinch, grab, touch the white part as this person is doing, but never touching the dark yellow, yes? And holding the glove through this folded inner part, you are going to introduce your dominant hand inside, yes, without touching in any moment the outside of this. And then you pull the white part, and then spontaneously is going to straighten up. You don't need to straighten up. Now that this hand, the dominant, is sterile, here is sterile, you can touch the other glove, the one that is left here, the other touch, but you can touch the sterile part. You don't touch the white part, you touch the yellow part. And for that reason, you introduce your fingers inside the pocket made by folding the glove. You can visualize that there. And doing that, always doing that, touching the sterile part of the other glove, then the other hand is going to be introduced and put. Take care with this thumb. Don't touch. It's here. That's why when I was taught that many years ago, I was said you need to keep your thumb, okay, abducted, just abducted all the time to avoid this stuff that you see here. It is something edit, okay, edit. To remove, okay, you are removing first the non-dominant hand. So it's all the way around. Yeah? You remove first the non-dominant hand. To remove, you need to take care of not touching the skin because now the globes, the dark yellow, are dirty, are contaminated. Yes, so please don't touch the skin. Okay, with your dirty, okay, globes. So you pinch the border of the globes and pull it out. Notice that when you remove this first globe, you keep this globe, okay, grab, you know, by the hand that still has the globes. So now with your bare hand, you introduce your finger under the globe. Outside is contaminated. Inside is clean. So now you just your fingers there and you pull inside out over the grabbed, okay, globes, and that's it. And this is what is called the double globe technique. So this globe is going to be inside the other globe. And if, for example, if you have here something very contaminated, you can keep this something very contaminated here, and this is going to be inside the first globe and inside the second globe. And, you know, it's a good, elegant way of throwing away in biohazard something very contaminated, something very dirty. Yeah. The vaccination, the most common question that I think about vaccination are related with the live virus vaccines and the influenza vaccine. Those are the high topic of the vaccine. You know that the vaccines our children receive, the first vaccine is hepatitis B. There is not too much. This is given intramuscular, vastus lateralis, yeah, and has 3 doses in total. Is given before leaving the hospital. It's the first vaccine received. Yeah. Then, when the child has 2 months of age, 6 to 8 weeks of age, is going to visit the pediatric to receive the second dose of hepatitis B and the first doses of all this. So at least you should know the name of the vaccines. An interesting detail is that the only, and this is something that brings a lot of confusion to Hispanic students, which is the majority. The only oral in drops, oral vaccine in America is rotavirus, no polio. Here we don't give oral polio, it's prohibited. Yes? So I noticed with certain frequency this misunderstanding or lack of knowledge in some of my students. In case you are still in this group, take care. The only oral vaccine given in America is rotavirus. This is a virus that produces diarrhea in children, and on purpose is given orally because we want immunity in the lymphoid tissue of the intestine, where the immunoglobulin A, the secretory immunoglobulins antibodies, are produced. The others are DTaP, diphtheria, tetanus, excellular pertussis, the inactivated poliovirus, Haemophilus influenza B, and the pneumococcal conjugated vaccine, 13 serotypes. I call this the 13, la 13, the 13, yeah, which is the pneumonia vaccine given to children. It's important to remember that because in adults, when you reach your 65, you will receive that again, but you are going to receive another one, which is the 23. So you receive the 13 and the 23. Okay. So that's it. You need to know. You need to know that those vaccines are given. Now comes, yes, any question? Okay. Now comes the live virus vaccines. So you need to memorize MMR and varicella are the live virus vaccines given here in America. There is a vaccine that is live virus. You need to know that exists is yellow fever, but we don't give yellow fever vaccine in America because we don't have yellow fever here in America. Okay.
Professor,
MMR.
And TB too, tuberculosis too.
In America, we in the first world, in Europe, Japan, Korea, South Korea, and the United States, we don't give BCG. The BCG is the vaccine of the bacilli of Calmette. Getting, take care, because this is the way that is mentioned in English. They don't say BCG. They don't say BCG. They say vaccine of the bacilli of Calmette getting. You know that that's the reason of the BCG. Yeah, is not given in America because first, it not prevents tuberculosis, and second, tuberculosis is not common in America. For that reason, it's not worthy to give this vaccine. The purpose to give this vaccine in countries where tuberculosis is frequent is to prevent is to decrease the risk of developing severe forms of tuberculosis. The BCG doesn't prevent tuberculosis, but could avoid severe form of tuberculosis. like meningeal tuberculosis, like miliar tuberculosis, etc. So it's not worthy to expend effort and money in giving the BCG in countries where the tuberculosis has been practically eradicated, because it is not useful to prevent the few cases of tuberculosis that exist. This is the explanation for which BCG is not given in America. So incorporate also this detail, okay? The only important that you can have in Nclex about BCG is that if a client receives the BCG within 5 years, okay, in the last 5 years, this BCG could make the PPD, the purified protein derivative skin test, the tuberculin test, positive. And it brings confusion because now the patient can have a latent tuberculosis, which is the one that produces positive PPD, and we could blame the BCG when the patient could have latent tuberculosis, because a person who received BCG can catch tuberculosis and have a latent tuberculosis, okay? So could be a cause of false positive or a source of confusion in the diagnosis of latent tuberculosis.
Professor, let me ask you a question. Live attenuated influenza vaccine, the one who is used in
but this is a no palenque. This is not in English, okay? This is a nasal flu, the nasal flu, okay? The nasal flu. And of course, the only important that should not be given to immunosuppressant pregnant women.
Yeah, but it's not in English. Because I saw some question.
Yes, Nclex is working with the flu vaccine that should be given to people. This nasal flu, was taken from the market, now returned for the market for economic reasons, but it's a nonsense because it cannot be given to small children, cannot be given after 45, cannot be given to pregnant women. So there is no reason for the existence of this flu vaccine. The most important of the flu vaccine is giving that to small children, to pregnant women, and old people, because small children, pregnant women, and old people are the ones that are killed with the flu. Yes, and the nasal flu cannot be given to this population. So that's why it's a nonsense. Okay, Nclex works with the shot, the genetically engineered antigen flu vaccine.
Okay, thank you.
But a good question, yes, because it's true. This is live viral vaccine, the nasal flu. Esa no va para el Nclex. Don't.
Profe,
Diga.
can I ask you one question?
Sure.
I'm sorry for my ignorance. You said that for tuberculosis.
Nobody's ignorant, mija. Aquí nadie, the only ignorant is the one that doesn't ask questions.
You said that for tuberculosis, there's no vaccine, right? You said?
For tuberculosis in America, no vaccine.
And how it was eradicated? ¿Cómo se erradicó?
Improving the hygiene and the population, the nutrition of the population, and having a very strict control of the cases and their contacts. If you appear with tuberculosis here in America, the state take care of you. Immediately you are identified, and you are going to receive direct observation treatment, DOT, direct observation treatment, until you are cured. You understand? So that's the way they have practically eradicated tuberculosis in America and in Europe. For example, in Europe, you have a contrast between Europe, West Europe, okay, and Russia and East Europe. They have tuberculosis. They have a lot of tuberculosis, but it's just a problem of hygiene, nutrition, and public health. That's the way they eradicate.
Yeah. Okay, thanks.
The development. Okay. So varicella, MMR has stand for mumps, measles, and rubella, and varicella are. Remember that most of these shots are intramuscular, but the live viruses are subcutaneous. I think it's an interesting detail because you know what? Who give those vaccines? The nurse. Doctors order the vaccine, you get it. And then it's so useful that all those vaccines, hepatitis B, and all these vaccines are intramuscular. The one that are subcutaneous of the live viral vaccine. The influenza is very, 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 so you know, okay, I assume that everybody knows that the problem of the live viral vaccine is that the virus is alive, is weak, is attenuated, cannot produce disease, but is live, is alive. And if a person with depressed immunity have this virus, even being attenuated, being weakened, then the virus can produce the disease. So cannot be given to a person with AIDS, cannot be given to a person that has, ¿cómo se llama? Chemotherapy, a person that is receiving immune suppressive therapy because of transplant, etc. That's why those people should be vaccinated before the immune suppression develops. That's why it's so important when the patient is diagnosed with HIV, before the patient develop immune suppression, to check if they are vaccinated or not with that, because you know that you can have HIV, but you still aren't immune suppressed. You still don't have AIDS. So you can receive the vaccine if you are immune competent. A patient that is infected with HIV can have a CD4 count in 100 and can receive those vaccines, okay? But should be received before they deteriorate. Thanks God now if they get a good treatment, they don't deteriorate. The other individual that is immune suppressed is called fetus. Fetuses are immune suppressed. So if you administer this vaccine, the mother is not going to have any problem because the mother is immune competent, but the fetus is immune suppressed. And for that reason, is going to be affected by the weakened virus that infects the fetus. That's why those live viral vaccines cannot be given to pregnant women. And the other problem of the live viral vaccine is cannot be given before 1 year, because in the first year of life, the baby has antibodies passed from the mother who is adult and immune competent and has immunity against those diseases. So if you give the live viral vaccine, the virus needs to be alive to produce immunity. If the virus is dead, the vaccine is going to be like water. It's not going to work. The virus needs to be alive to trigger immunity in the vaccinated person. But then the antibodies of the mother that are still present until the first year of age are going to kill the virus, so the vaccine is not going to work. That's why those vaccines need to be given after the year of age, and this is tested. And the explanation is that, and if you pay attention and you are able to understand my Spanglish, there is no need of memorizing that. You understood that. The other problem with the live viral vaccines that have been tested is that some people are injected antibodies, monoclonal antibodies. You should know what is that. Immune globulin, gamma globulin, etc., etc., etc. Okay? And when they receive this immune globulin, have these people antibodies in the body against those weakened viruses that are in the vaccine. If a person receives immune globulin, gamma globulin, monoclonal antibodies, and anything that could affect the vaccine, needs to wait 3 months to wear out those antibodies to then being vaccinated. Are you clear? Do you understand why the fact that being a live viral vaccine have these exceptions and precautions? We can move. Okay. The problem of the influenza. Influenza needs to be given every year in fall until you die. The rest of your life. Starting at 6 months of age, you can start. So it is important. You start at 6 months of age and you stop when you die. That's it. Period. Simple, sencillo. Is that virus should be given in pregnancy. In pregnancy, it's recommended the vaccine. Is no virus there. It's just antigen. Okay, it's just antigen. Is genetic engineering. Okay, vaccine is antigen only, and that's it. What is the problem of the flu vaccine? Two, and have that clearly. People receiving aspirin, and there are people that need to take aspirin, but no people, children and adolescents, okay? Children, no people, children and adolescents, okay? Children and adolescents, okay? No people, sorry, I used the wrong word. Children and adolescents taking aspirin, and you need to know the aspirin is needed in certain conditions, like Kawasaki disease, like rheumatic fever, could be rheumatoid arthritis, okay? Whatever. The child is receiving aspirin, cannot receive the vaccine. Because the combination of the virus of the flu or the virus of varicella. So now we need to add here in this issue varicella. Okay, flu, influenza, flu vaccine. Varicella, chickenpox, yes? Both are viral diseases. If this virus are, or the antigens of those viruses are present in the body, together with aspirin, can trigger an inflammatory condition called Reye syndrome, in which the brain inflamed, swelling, encephalopathy, swell, and encephalitis, and the liver swell, inflame also with necrosis, and could be mortal. See? So flu and varicella, either disease or vaccine, no with aspirin. Understood? And remember that aspirin is in the family of salicylates, because sometimes the question doesn't say aspirin, this says salicylates, because there are other salicylates that are not necessarily Bayer aspirin that are also producing the problem. It's clear. Did I explain myself well? No question? So there is a contraindication to vaccinate a person, not a person, a child, adolescent are the one that can develop Reye syndrome if they are taking aspirin. Please remember the detail. That's why we tell parents, don't give aspirin when your children have fever, because could be flu or varicella, and then they could develop Reye syndrome. Yeah. So the best is any fever, no aspirin, because you are not doctor to decide if it is varicella or influenza early. Okay, very good. So clarify the detail of those vaccines and aspirin. So those vaccinations need to be postponed for the moment in which the child or the adolescent stops taking the aspirin, because they are not taken forever. Easy. Period. Apart. The other condition is Guillain-Barré. Guillain-Barré could be triggered by in the virus of influenza. The most common cause of Guillain-Barré is influenza. So for that reason, the vaccine of the influenza could trigger Guillain-Barré. The statistic says that for one in every million shots of influenza can produce Guillain-Barré. Very rare, extremely rare. That's why I continue receiving my flu shot, because I know that flu, the disease, la gripa, yeah, can produce Guillain-Barré frequently. No 1 in 1 million, 1 in 100, 1 in 500, yes? So I don't want Guillain-Barré in me. But I know that is 1 in 1 million, okay, probability of triggering Guillain-Barré when I receive the vaccine. I know that. This is my risk. The same as many other vaccines, okay? Okay, point apart. So the problem is that if a person already had Guillain-Barré, could be risky, could be problematic receiving the vaccine or the influenza, because it could trigger recurrence of the Guillain-Barré. You understand? So it's the only recommendation that the Center for Disease Control experts says in relation of contraindication of the flu vaccine. If you're taking aspirin and you're a child or an adolescent, postpone the vaccination. 2, if you are any age person who had in the past Guillain-Barré, consult with your doctor the risk and the balance, the pros and cons of receiving the vaccination, because there is a remote but possible risk of triggering again Guillain-Barré. Understood, no? Okay, I explained that very simple, very, sometimes okay, too simple. Okay, ¿qué era lo que me faltaba allí? Okay, in the past, we thought that people allergic to egg, okay, the stuff that put the hen, no, egg, okay, should not receive influenza vaccine. Forget it. If I said that to you, forget. I was wrong. CDC said that the research has demonstrated that there is no reason for not receiving the flu vaccine because you are allergic to egg, period. If you want the details, you have many details, you can go to the CDC and they'll give you all the information. But no anymore, please, for Nclex. Remember that you go to Nclex to pass the Nclex, not to teach the Nclex or to discuss with Nclex. Yes? Nclex follows CDC. CDC expert says we have reached the conclusion that allergy to egg is not a contraindication to the flu vaccine. Are we good? To make it simple, okay? Of course, if you receive the flu vaccine in the past and you develop an anaphylaxis, could be a contraindication, or at least you did receive that in the hospital, okay, with a lot of medication to prevent anaphylaxis. But this is not the case of the egg, nothing to do with the egg, okay? That's it. Mir, flu and pneumonia vaccine, flu and coronavirus vaccine can be given the same day. Was tested. That's why it's here. I add to continue each time there is something that appears in the English. I add that because it's true and it's a common situation. It happened to me. I was due the booster of the, ¿cómo se llama? Of the coronavirus, and also due with the flu vaccine, and I received both the same day. You understand? Because it can be given. The science say that I can be given. There is no reason, no problem with that. Okay. So flu and pneumonia vaccine and flu and coronavirus vaccine can be given the same day, just in case. I know it is the schedule that they publish for the people to understand the kill vaccination, but there is nothing different from the one that I told to you. If you want to read a little more, about in the PowerPoint that I'm going to publish is a summary of what CDC says about the allergy to egg, etc. Here you can find this information more detailed there. Okay, remember that the PowerPoints have in the bottom notes that I can add. Oh, this is to remind you the vaccines in the adult people. Adult people need to receive the flu vaccine every year until they die. Second, every 10 years, okay, every 10 years should receive tetanus, diphtheria, acellular pertussis called Tdap every 10 years, a booster every 10 years. Don't forget that you should have that. I think in the school they require you to do that, so maybe you, unless you are my student, because my students suffer of Alzheimer, but if you are not my student, probably you are normal, you remember that they request, okay, the booster, demonstration of the booster. Every 10 years, okay, every 10 years, a booster or Tdap, okay? Probably you receive that. My students forget that, but they know who I'm talking. And the other vaccine that you need to receive when you are adult, okay? Because the other vaccines is just if you have never received that. If you are coming from, I don't know, from Antarctica, you are coming from I don't know what country they were that don't vaccinate, and you have not been vaccinated, they vaccinate as adult. But the vaccines of the adult is the flu, the booster of the Tdap, okay, every 10 years, and the pneumonia, the pneumococcal vaccine that is received when you are 65. But you receive two, the 13 and the 23. Please remember that it is what is necessary, mandatory for adult. The other are optional, okay? Are optional. Following injection of MMR vaccine, the nurse should make priority assessment for which of the following client manifestation: fever, pain, and recurrent sign of injection, wheezes, or vomit. What do you think?
Wheezes.
Wheezes. It's just to highlight that any vaccine, any tablet, any shot, any food could produce allergy in some people. Some people eat shrimps and develop, okay, anaphylaxis. Some people eat peanuts and develop anaphylaxis, okay? Some people receive a Tylenol and develop anaphylaxis. So the same happens with the vaccine, okay? So have in mind that anybody could have, for any vaccine, an allergic reaction. Let's see this. 1-year-old child with Kawasaki disease receiving intravenous immune globulin. This is part of the treatment of the Kawasaki. How this affects child's vaccination. Flu vaccine can be administered because can trigger the disease. MMR vaccine must be delayed 11 months after the IBD. It is true. It is not 3 months. It's 1 year. Sorry, I said a mistake. I said 3 months. It's 11 months. Doctor will order withholding aspirin after the DTaP vaccine. Hepatitis B vaccine must be delayed 6 months after IBG. What do you answer?
A.
Okay, Kawasaki disease in this case is not receiving aspirin. The question say is receiving immune globulin. The immune globulin will affect live viruses. Yes? So the only live viral vaccine is this. It is true the Kawasaki, okay, is also treated with aspirin. But aspirin is not given all time. Aspirin is given in some period of time and then it is continued. But Kawasaki is also treated with IV immune globulin. Yes? The question say that the client is receiving IV immune globulin, no aspirin. You accept the question as it is coming. The issue is that is receiving IV immune globulin. Yeah? So the problem with the immune globulin are the live viral vaccines. And the only live viral vaccine that we have here is MMR. So the best answer of this question is B as in boy, because the MMR vaccine cannot be given while receiving the IV immune globulin, because then this immune globulin will kill the live virus of the MMR, and there is no reason then to give this vaccine if they are going to be killed, you understand? So need to be delayed 1 year after the IVG. It's 1 year, guys. I said 3 months because I was thinking in other stuff. Is 1 year, yeah. Remember, so after 1 year of injected antibodies, either from the mama, okay, or artificially, is when is given the live viral vaccine. Do you understand now? Okay, if the question say is receiving aspirin, the aspirin it contraindicates the flu vaccine, not because triggers the Kawasaki, because produces another disease called Reye syndrome. The flu vaccine, okay, cannot trigger Kawasaki. The flu vaccine, if the person is taking aspirin, can produce a disease called Reye syndrome, okay? ¿De acuerdo? So this is not correct for that reason. First, because they don't say that it's receiving aspirin at this moment, and second, because flu vaccine doesn't trigger the Kawasaki, okay? So remember that sometimes, you know, the questions are a little more tricky, and you need to be careful with that. The varicella, chickenpox, the problem that you have is recognizing the disease in picture. In Nclex, they give you pictures of children with chickenpox. So I think I have some question por aquí. Like this. Something like this. No? They can give you a picture, yeah? And then they make the question. Based in this picture, you need to know that this child has varicella. Okay, so to give you an idea of how can be tested that. Okay, so a lot of Google image to see pictures of varicella, so you develop the recognition of the characteristic of the rash of the varicella. Okay, so that's it. Remember that varicella can later in adulthood appear as herpes zoster. You know the rest. Why trim nails? Because this itch a lot. So you don't want the child, you know, scratching those lesions. Rubiola is the same as measles. Hispanic people can have problem with this because if the Hispanic student is coming from a country and has previous experience of name of diseases in Spanish, rubiola is not the same as in Spanish. Rubiola is the same as measles. And rubiola or measles is sarampión in español. Okay, so rubiola is measles. The most contagious of all those diseases, even more contagious than tuberculosis. Yes, very, the most contagious is measles. Okay, and has a characteristic that is tested: Koplik spots. Those are the Koplik spots. As you see, those are the teeth, the molars, no? Las muelas, molars, yes? And this is the mucosa of the cheek, yeah? These white bluish spots over red mucosa are called Koplik spots and appears before the rash in the skin, the rash in the face and the trunk of the measles. So these Koplik spots allow to diagnose early the measles. Rubella, also called German measles, is a very benign, very mild viral disease, okay, but is highly teratogenic, and for that reason, should be avoided. But it's teratogenic in the first half of the pregnancy, before the 18 weeks. After week 20, is not producing any malformation in the fetus, okay? So the problem of rubella is in the first half of the pregnancy, in the early pregnancy. It is tested in Nclex. We commented that in OB. Mumps the mom, the same as paperas, no? That can produce orchitis and sterility in men. Notice that children of my times, in my times, guys, we didn't have vaccine for any of those diseases. So children of my generation used to have all those diseases. Yeah. Some die. The most mortal of these four is the measles. Okay. Majority survive. Okay. Like me. I had all of them. All of them. Yes. And then when our parents say, oh, Carlito had all the diseases of the childhood, came a fifth, 1, 2, 3, 4, 5, a fifth fever and a fifth rash. ¿Qué tiene? ¿Qué este muchacho que tiene? Is the fifth disease. Okay, the doctor's name is Erythema infectiosum, but in Nclex is mentioned the fifth disease. The rash is so typical, so characteristic that is easily diagnosed. It looks like slapped cheek. You see that? So it's localized in the cheek, like slap cheek. Yeah. When the rash appears, that appears generally after the 2 days of fever, the child is not contagious anymore. Before the rash appears, the child is contagious and is droplets. Is the B19, the parvovirus B19 o sea, the P of Spider-Man, was I was trying to say that, the P of Spider-Man, okay, together with pertussis and pneumonia, pertussis, and parvovirus, okay? No treatment, no vaccine, benign condition, that's it. Pero know it because anchors like to make question about this. I don't know why. Mononucleosis. Infection mononucleosis is a viral disease. This is the name of the virus, Epstein-Barr, that produces huge lymph nodes in the neck, a very disgusting tonsillitis that is difficult to differentiate from a strep throat, and the most important, huge enlargement of the spleen that can break and can become then an emergency. Mononucleosis is benign. It's a child, an adolescent, or young adult. Fever. A lot of malaise and tiredness. Is an intense fatigue, tiredness, acostado todo el tiempo. And a lot of sore throat. Terribly sore throat with a very inflamed tonsil. The voice is like a potato voice. If you were having a potato in your throat, no, it's not. I cannot reproduce that. Like you have a potato in your throat. This is potato throat. Okay, when you have a voice that when you're speaking, you look like you have a potato in your throat. So it's called
You're so funny, pero
potato throat. Potato throat. And the lymph node huge. And this is the most important, the splenomegaly. The disease in 1 week it's gone. Okay, no antibiotics, only relative rest, Tylenol. But then the spleen stays enlarged for a little while. And it is a disease of children, adolescent, young adult. What are doing those guys? Running, playing basketball, etc., etc. You understand? And then there is a risk of a splenic rupture that requires then a splenectomy and emergency surgery. And even I read in the news from time to time, children, adolescents who had this splenic rupture playing football, American football, and they ended that they had a very mild mononucleosis, were not diagnosed, because sometimes it's not so severe, no? Sometimes not so severe, so it's not diagnosed, and then they have a splenic rupture. Don't forget the stuff of the splenic rupture. That is the most common question about infectious mononucleosis. Shingles, there are many questions in Nclex of shingles. Take care. First, they give you the picture. So please, again, practice pictures of shingles, okay? Generally, what you see is a cluster. Cluster means group, no? A cluster, this is a cluster, this is another cluster, this is another cluster. A cluster of vesicles. Vesicles are the mark of the varicella and the herpes zoster, and are appearing those clusters along the track of a nerve, more frequently an intercostal nerve. This is the nipple of this man, and is growing from the back to the front and then stop here. Okay, that's it. This is contagious. In this liquid, the virus is present. This person that has shingles, I can assure 100% with certainty that this person had in previous years varicella. Only people who had varicella in their life can have shingles. Okay, so shingles is a reappearance of the virus, the varicella, but limited to a nerve. Can appear more than once. The older, the more severe the shingles. The worst shingles is the one that is in the trigeminal nerve, because it can affect the cornea and produce blindness. Okay, is in this order, can leave scars. Okay, one of the most a person who is not immune against varicella and and touches those lesions can catch varicella, not shingles, varicella. So shingles can produce varicella in other people. There is one Nclex question that says which one is the most important question for infection control to ask a client with shingles? And the right answer: somebody in your house has not been vaccinated or is not immune, has never had varicella. So is somebody in your house who is not immune against varicella? Because then this can catch the varicella from these shingles. Second, shingles produce a lot of pain. So pain is the main problem. This is frequently tested. Which one is the most important medication to be given in shingles? And is the pain medication. And third, acyclovir cannot cure the shingles, but can make the shingles less severe. Yes, acyclovir is an antiviral medication that could shorten and appease the severity of the shingles. Herpes zoster, no, varicella zoster virus, the virus varicella, could be teratogenic. So a pregnant woman should not be dealing with any of those viruses that are transmitted through the air, either droplets or airborne. Is what the OSHA, the organization that had to do the health protection, etc. OSHA says about pregnant women working in hospital that should not be, specifically nurses, should not be dealing with clients that have droplets or airborne diseases. I don't think you have any question about the shingle vaccine because it's not mandatory. It's a luxury. Lyme disease. Nclex is asking question. Delante, para atrás, atrás, para adelante. Many questions about Lyme disease. But very simple question. What you need to know about Lyme disease. First, it's a bacterial infection. The bacteria is inoculated by a tick. The tick is normally found in the forest because it's the tick that parasites the deers. So it's a tick that is not found in the cities, in the bush of the cities, okay, or is in the forest, okay. So generally the scenario is somebody that is in the mountain, is hiking, is working in the mountain, is somebody that is in the forest, and it is the type of tick that can transmit the bacteria that produces the Lyme disease. They make many questions of how you avoid being bitten or parasited by the tick. So when you go to the forest, wear long pants and long sleeve shirts, and tuck your pants inside your sockets. O sea, mete el pantalón dentro de la media. Try to use clear colors. Don't use dark colors for reasons that we don't understand well. The tick love to jump into dark colors, maybe because they think that you are a deer, no? So if you wear clear colors, there is less possibility that the tick jumps onto you. You can spray repellent, okay, in your cloth, okay? The most commonly repellent that is not toxic is called DEET. You see this, it is an insect repellent that can be used against mosquitoes and ticks and all those bichos, okay? So just in case, because I saw in one question, they mentioned DEET, and this is the most common stuff that you spray when you want the mosquito repellent, etc. And it's not toxic. What else, Bajing? And if you are walking in a trail, trying to walk in the middle, away from the plants, the bushes, because there is where the ticks are. And when you come back from your activity and you're in your house, if a pet, a dog, was with you, please check the pets to remove any tick that could be seen in the pet. And you need to check yourself if you have ticks. If you have ticks, remove the tick with tweezers, being careful of removing the head, that is the one that is attached to the skin. Don't burn, don't crush the tick, just flush the tick and the toilet. I am so detailed because precisely Nclex is detailed in the prevention and management of this. If a person had a tick bite, should wait either for the appearance of a flu-like syndrome. Flu-like is mild fever, malaise, arthralgia, pain in the joint, enlarged lymph node, or the appearance of this rash in the site where the tick was biting. That is the classical bull's eye skin lesion. Bull's eye means target, la diana in Spanish, tiro al blanco, yes? So it means bull's eye, okay? Has nothing to do with the animal, okay? It's just because bull's eye is the way that, in English is called this stuff, okay? And to play dart, okay? And it is unique and growing, and then the patient is having the disease because the symptoms. There is a blood test. There is a blood test that confirms if this is true Lyme disease. And this blood test uses the same laboratory technique that uses the HIV testing. So the technique is ELISA and Western blot. ELISA to screening and Western blot to confirm. But it's ELISA for antibodies against Lyme disease instead of ELISA. They are ELISA for HIV, ELISA for Lyme disease, to understand, okay? And if this disease is not treated at this level, then can become chronic with a lot of arthritis, nerve inflammation, polyneuritis, Bell's palsy. Bell's palsy, paralysis, the seventh cranial nerve, and paralysis of the muscle of the face is very frequent, and even can produce a chronic depression, psychiatric issues. The treatment is with antibiotics. The oral treatment is tetracyclines, specifically doxycycline. The parenteral treatment is with penicillins, including cephalosporin. Okay, so penicillins and tetracyclines are the treatment. Doctors will decide which one. So, for example, they can say, Nclex question, the patient has a Lyme disease and is allergic to penicillin. What antibiotic do you expect the doctor to order? And the answer is tetracycline or doxycycline. Okay. The blood test takes between 4 to 6 weeks to become positive. So since the moment that the person is bitten by the tick and the test become positive can pass, 4 to 6 weeks. So it's very frequent that the patient has the rash, the epidemiological risk. So it's a person that is working in the forest, and doctors, and the test is still negative, and doctors decide to initiate the antibiotic, and later the test become positive. So those are the details that I see in Lyme disease that you should know to be able to answer all the simple question of Lyme disease that are very frequent, but very simple, very easy.
Profe.
Yes.
If I recall well, in Nclex, it appeared a picture, I think it's almost exactly as that one, the Lyme. And they asked me for contra precaution. I am not sure that that's the picture, the round thing with
something. It is a standard precaution.
Standard?
Yeah.
Okay, thank you.
Standard precaution. Okay. Standard precaution. Okay. This cannot be passed unless the tick bites you. So the problem is the tick, not the person that is infected. Okay, this is standard, definitively. Thank you for your report.
Okay, thank you.
Okay, impetigo. Okay, impetigo is an infection in the skin very frequent in children, and is a staphylococcus or streptococcus. And if it is a streptococcus, remember that the streptococcus can produce acute glomerulonephritis, the inflammation in the kidneys. This is the way that I see more frequently tested in Nclex, impetigo. That impetigo is a silly disease, very contagious. Impetigo is contact precaution. It's very contagious. Okay? I remember I suffered a lot of impetigo when I was a child. But impetigo can produce glomerulonephritis. Please have that in mind. They make sure.
A quick question in reference to that. I have a question in the Nclex that they asked me if the mom is able to wash to take out the crust. Yes, that was the question. And the other option was to be 24 to 48 hours.
Yes, yes, it is true. After 48 hours with antibiotics, yes, the contact precautions are kept until 48 hours of antibiotics. After 48 hours of antibiotics, the contact precautions
can be removed. Okay.
Can be removed.
So can the mom take out? Can the mom
there is no reason. There is no reason to remove the crust.
That's the one that I put that was incorrect. So that was good. Okay.
The crust will fall spontaneously. It is going to leave an open skin that is going to be, disseminating. The mammae is going to be disseminated all over
Even I look after that. I went to Yoan, and Yoan has an explanation that they can wash it, but
wash and water, wash and water, okay. And a lot of hand washing,
Thank you, Professor. Thank you.
This is thank you also for your. Yes, that's why it is here, no? Because after 48 hours, it can be left. It's not contagious anymore. I had a lot of impetigo as a child, a little break, and this is something that have a water, no? A secretion, watery secretion, and where the watery secretion falls in healthy skin, appears the lesion there. So yo me llenaba de impetigo because when you are a child, you don't have immunity against those bacteria. As you grow older, it's very rare this disease because you develop immunity against those bacteria. Yo era muy tremendo, me la pasaba en el monte todo arañado. Guys, ringworm or tinea, which is fungus in the skin, there's a mycosis in the skin, is very frequently tested. Sometimes they describe ring. Look at this lesion. Do you see there are ring? Okay, ring. That's why it's called ringworm. Yes, that has nothing to do with a worm. Okay, so those are rings that are also the same as impetigo. It's more frequent in children because they still don't have immunity against those funguses. So notice that the fungus, the infection start growing in this direction, no? In this direction. That's why the ring starts small and start growing, it start very small and they start growing, okay? And this is called tinea or ringworm and appears in the parts of the body that are moist. So that's why it's more frequent in the groin, it's more frequent in the feet, because are the part of the body that are moist more frequently because the sweat. There is a question in Nclex, in which time of the year is more frequent the tinea, and you need to answer in summer because people are sweating more frequently. Tinea pedis so frequently because in athletes, because athletes are sweating the feet a lot and use the footwear that is usually promoting the sweat, etc. You can have pictures and then you identify that as a tinea. And remember that antibiotics are not useful for this. We use the antimycotic medication. And remember the antimycotic medication, the prototype are the azoles. Azoles are ketoconazole, clotrimazole, itraconazole, miconazole, ketoconazole, all the azoles, okay? So this is the medication. And keeping everything dry. ¿De acuerdo? Dry. Many questions of pediculosis, guy. Pediculosis has two forms. The adult lice, which jumps and can infect you by contact, and the eggs that are the nits. Eggs are not contagious until they hatch and the adult is coming out. The adult is yes contagious, the nit is not contagious. For that reason, when a child is diagnosed with pediculosis, should be sent home in contact isolations, yes, and should be prescribed permethrin. We don't use any other anti-pediculosis medication here. We don't use malathion, we don't use lindane, we don't use any other except permethrin, which is not toxic. It's the approved, yeah? And then the child will have a shampoo with permethrin. After 24 hours of the permethrin shampoo, all the adult lice are going to be killed, okay? And the child will be left with only the nits. The child with nits can, yes, by the CDC, can, yes, go after 24 hours to the school. Okay, cada vez que yo hablo de pediculosis me empieza a picar la cabeza. Okay, so can go to the school. Everybody happy that. So can go to the school. Can go to the school. This is in the Nclex. Okay. Of course, the nits need to be removed mechanically with the little comb. And then 7-10 days later, a second dose of permethrin is recommended. Meanwhile, all the linen, personal cloth, whatever, should be washed with hot water and dry in the electric dryer in the hot cycle. Is enough with that. If there is any stuff that could not be washed, like a hat, something that is too delicate to be washed, can be placed in a plastic bag, okay, sealed, okay, closed for 1 week, 2 weeks there. And then the lice will die that could be in those items, will die of that. Important. Dogs, cats, and pets don't catch lice, don't need to be treated. And there is no need to spray insecticides because they are toxic, but you can vacuum, okay, the room and the house just in case any nit is on the floor. That's it. This is what you need to know. There are frequently set of that applied questions about this. For scabies, that is similar, is contact, etc., they insist a lot in recognizing the lesions. They give you pictures and also descriptions. What you need to know about scabies is that it is a tunnel in the dermis that is called the burrow, okay, where the parasite, which is an ectoparasite, let's say as the lice, enters in the skin and drill the tunnel in the dermis. So you see the point of entrance, and you are going to see a wavy line. So it's not straight, it's wavy. Generally, it's wavy, okay, of the parasites advancing under the skin, on the epidermis, and is laying eggs in the way. So that's why this is the classical burrow, okay, or waving red lines that can be seen. The place of entrance of scabies in 90% of the cases is in this soft tissue that we have between the fingers, the interdigital webs that we have there. This is tested in Nclex. Okay, the acquisition is by contact, and this is the place where the first lesion appears, very itchy. And then it's very contagious, disseminate all over the body. So you are going to see you see here the burrow, or the shorter burrows when you see two papules. One is where the parasite entered in the past, and the other papule where the parasite is. So you are going to see always something like this, like, shorter, okay, burrows, but you see two papules, okay, parallel papules, okay. That's it. The treatment is permethrin, need to be given all the body, and is repeated again 7-10 days. And pets don't need to be treated. It's not true that perros son sarnosos. No, pets don't catch scabies, but you are maybe have heard or seen of perro sarnoso. I'm talking in Spanish because I don't know if it's a fungus in pets, in cats and dogs, okay, called mange, okay? So it is not, eso no existe, perro sarnoso, it doesn't exist, okay? Pets don't catch, okay, scabies, period. And that's it. It's interesting that the pruritus can persist even after the treatment, because the cadaver of the parasite is left in the skin, and then it can have an antigenic, okay, reaction. Let's see this. Well, inserting a nasogastric tube, okay, nasogastric tube. The nurse should use which of the following protective measures. So you have 4 combinations here. Okay, you have gloves, gowns, goggles, and surgical cap. Sterile gloves, mask, plastic bags. Okay. Sterile gloves disqualify the option. You don't need to use sterile gloves based on what we discussed for nasogastric tube. That is a clean procedure. Yeah, so I can rule out this to make it less complicated. Okay. Double gloves is the only, listen, the only disease, infectious disease, where is recommended double glove is Ebola. And Ebola no va para el This is not, it's too complicated. Ebola is a very complicated disease. I know that if you do UWorld, etc., you are going to have questions about Ebola, but forget it. Ebola is not in English. It's too difficult for being tested, okay? So double gloves is a no-no, and you are just introducing nasogastric tube. So please, you rule out that. Is it what I do? Because when I see so many details, I become confused and it's difficult. So let's see, gloves, yes. Gown, yes. Goggles could be, because I need to expect a splash. But then I need to combine the goggle with mask. And what they say, surgical cap. So I don't need surgical cap. So need to be C. Gloves, yes. Clean gloves, not sterile gloves. Gown, yes, and face shield, perfect. Why? Because introducing nasogastric tube, the patient can vomit. And then you need to protect you from vomiting. You cannot prevent, you cannot anticipate if the patient is vomiting or not. So obviously it's good to use gown and face shield. Remember that this is Nclex. Remember that this is Disney World, okay? That everything is clean and perfect and organized, okay? So it's the theory. We agree? Can we move? Yes. A 21-year-old male client has developed infectious mononucleosis. What factor in the client history is most important in developing his discharge teaching plan? He regularly eats at fast food restaurants. On weekends, he usually drinks 2 beers. Lately, he has been sleeping 10 to 12 hours. He works as a furniture mover. What is the most important aspect here?
D.
D.
D as in diamond, no? Yes.
Yes.
Because the spleen, you remember? So this is the kind of questions that can be in English, that those questions weigh more points than other questions more elemental like this. Why? Because you need to connect two concepts, You need to connect the fact that the person is having an splenomegaly because it's said that is suffering infectious mononucleosis and is having a job that predisposes the person to abdominal trauma, like, transporting furniture. Okay. The charge nurse is making patient assignment for the day shift. Which patient should be assigned to an RN who is pregnant? So now I commented that. So we have measles, shingles,
No.
MRSA or BRSA, and chickenpox. Which one do you think is the least risky for this baby? No te oí.
C.
Yes, 3 is the one that brings, yes, least risk to this nurse. This nurse can perfectly control, okay, a BRSA, okay, BRE, with the infection control precaution. Nevertheless, it's much more difficult. There is more risk of catching an airborne or droplet disease. In the case of the shingles, remember that the virus that is in the shingles is the same chickenpox. So I said, because those viruses can be teratogenic, okay? It's no good. It's no good to have a pregnant nurse because, you know, accidents can occur. So it's not good to have a pregnant nurse dealing with viruses like the chicken pox, measles, and rubella that could harm the baby. The woman is no problem because probably is immune to all those stuff. But the problem is the fetus that is immune suppressed. Nevertheless, a vancomycin resistant enterococcus, which is a bacteria, is a bacteria that cannot affect the baby. And it's a bacteria that is easier to control, being careful with the hand washing, etc., etc. So that's why the best answer of this question is 3. A patient has been diagnosed with disseminated, you remember disseminated generalized herpes zoster, which personal protective equipment will the nurse need to put when preparing to assess the patient's select or that apply? So remember, generalized herpes zoster. So is airborne. Is airborne. Plus
Contact.
Content.
So now, based in this knowledge that you have, okay, so are you needing surgical mask or N95?
N95.
N95. Do you need gown?
Yes.
Yeah.
Yes. Do you need gloves?
Yes.
You don't need goggles.
No.
You don't need shoe covers because you don't expect a splash for assessing the client. So notice that everything
No
becomes
face mask.
okay. Face mask.
No face mask,
No.
profe.
No. Okay. Remember that in airborne, you don't use face mask. You use N95. Okay. Ay, ay, ay. Ay, 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 ay. Canta y no llores. Take the Nclex in the morning, not at this time that you are tired, okay?
Maybe that's why I failed it.
Okay. So take her in the morning and be very rest and don't study the night before. 4 patients arrive simultaneously at the ER. Which patient requires the most rapid action by the triage nurse to protect other patients from infection? So which one is the most contagious? A 3-year-old who has paroxysmal coughing and whose sibling has pertussis, so whooping, cough, possibly, and this is droplet, okay, droplets. A 5-year-old who has a new pruritic rash and possible measles. Measles, it is airborne. A 62-year-old with MRSA, it is contact. It's the least contagious until now because it's not air. It's not air, it's contact. A 74-year-old patient who needs TB testing because was exposed to tuberculosis patient in a recent international airplane flight, okay? So it could be or could not be TB, okay? But you know, it's a recent exposition. Do you know that when a person in our countries, in my country, is exposed to TB, first develop latent TB that is not contagious, and later, maybe years later, is when could develop active TB. ¿Ustedes saben eso? Okay, so you need to understand the natural history of the tuberculosis. It's a subacute and sometimes chronic condition. When you are a citizen of a country where TB is frequent, generally you get the bacteria when you are a child. The most frequent, the big majority of people getting TB in Venezuela, South America, and Africa, and wherever, is when you are a child. And then This bacteria live with you years and years as something called latent TB, and you are not contagious. But one day, because you develop immune suppression, because you are treated with prednisone, or you simply you grow older, then the defenses drop, and then the bacteria can multiply in the lungs, and then you develop active TB with symptoms, and you become contagious. Okay, so in this case, this gentleman has been exposed in the plane, a patient with tuberculosis was traveling, and then the Department of Health localizes everybody who was in this plane where the tuberculosis was to screen if they caught tuberculosis, latent tuberculosis. So if this person has latent tuberculosis, it's not contagious. So for that reason, I discard that totally. I discard the MRSA because the MRSA is not going through the air. So I need to choose between the droplets and the airborne. And of course, the airborne is going to win. The measles is the most contagious. The answer to this question must be 2. Do you agree with my analysis? Okay, let's move. The nurse is caring for 4 patients who are receiving IV infusion of normal saline. Which patient is at high risk of bloodstream infection? You know that is something called catheter-related sepsis, which is very fulminant, is very common and very, very bad. And depending on the type of catheter that you have more or less risk. So we have here, the patient has an implanted port. You need to know what is a port in the right subclavian vein. The patient who has a midline IV catheter in the left anterior decubital fossa. The patient who has a non-tunnel central line in the left internal jugular vein, and the patient with a peripheral inserted central catheter PICC line in the right upper arm. Which one you choose?
3.
I agree with you. This is the one that had the highest risk. If I ask you, and which one has the least, the menos risk of infection, which one you choose? Because could you say? Could you say? What you say? Exactly, the port. Very well. You are good. Okay. I don't know if everybody that is connected is okay. Let me show something. Si me dejan. Okay, just a moment. Okay. Let me show something. Just a second. For just in case anybody here is not clear in this aspect. Okay. 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 When you have a central catheter, it means that the tip, punta, is in the superior vena cava. When the catheter is in the superior vena cava, okay, the tip, if a bacteria can enter through the catheter, okay, can produce a very severe infection because the infection is going to be practically in the heart, and the heart is pumping blood with bacteria to all the body. That's why it produces the generalized sepsis. So definitively the catheters that have the highest risk of infections are the central catheter because the tip of the catheter practically are in the heart. But there are different types of central catheters. You have the peripherally inserting central catheter that enters in the antecubital fossa, very far from the heart. So yes, here you have a wound, you have open skin, and yes, bacteria can enter here. But it's very difficult for the bacteria, to reach all this distance until the heart. Makes sense? It's very difficult for the bacteria. Yeah. When you the pickle line will have less risk than a catheter directly introduced in the jugular vein or in the subclavian vein that is much shorter, much shorter. So a central catheter, okay, introduced in the subclavian, this is the subclavian vein, or in the jugular vein, this is the jugular vein, is going to be more prone to have an infection than a pickle line. Why? The distance from here to the heart is much shorter. Yeah. If we compare jugular with subclavian, jugular have by a statistic, by experience, a higher incidence of infection compared with subclavian. It looks that this area of the skin has more flora and more moisture than the subclavian area, but both are short central catheter with high risk of infection. Are we good? A midline enters here in the antecubital fossa and is inside the vein, but it stops here. So it's only here. So it's not reaching the central vein. It's called midline. Very useful to pass antibiotic, etc. But it is not a central catheter, so has no risk of infection as the central catheter. And just a second. And there is something called port. The port is a central catheter. The tip of the catheter is in the superior vena cava. But this catheter is connected to a port that is under the skin. And the skin, of course, 1 year ago had a wound with stitches and is already healed. So there is no way for any infection to enter here. That's why the port has the lowest risk of infection. What they did with this central catheter. This is a central catheter, but then the doctor first pierced or introduced the catheter in the subclavia. So the catheter is here, yeah? But now the doctor make a tunnel under the skin and make a second hole and take the catheter out and then closes the wound here. So now what did the doctor? Made a tunnel. It's called tunnel catheter. So now the site of the bacteria is farther, okay, from the heart down the non-tunnel catheter. So those were the examples mentioned there. The example mentioned there that okay, so the patient with the highest risk is the non-tunnel central line in the jugular vein, and the least risk is the portal catheter. Are we good? A hospitalized 88-year-old patient who has been receiving antibiotics for 10 days tells the nurse about having frequent watery stools. What disease you think has a person that is receiving antibiotics and has diarrhea?
Clostridium difficile.
C. diff, Clostridium difficile. Which action will the nurse take first? Now the question is difficult because it's a question of prioritization. What you do first? So everything could be correct, but what you do first, notify the doctor, obtain a specimen for culture, instruct the patient about correct hand washing, place the clients on contact precaution. What you do first?
Contact precautions.
Exactly. Number 4. This is the first that you do. Stop the dissemination of this infection. Now include the teaching, but and take the specimen for notify the doctor, requires the order for the culture and the treatment, the antibiotic. Okay. A pregnant patient in the first trimester tells the nurse that she was recently exposed to the Zika virus while traveling to Southeast Asia. Which action by the nurse is the most important? Another question of prioritization. 4 stuff that are correct, but what is the most important in this moment, in this scenario, for this woman that has the first trimester pregnancy? Arrange for testing for the virus. Discuss the need for multiple fetal ultrasounds. Describe potential impact of Zika in the fetal development. Assess for symptoms of rash, joint pain, conjunctivitis, and fever. What is the most important there?
4.
The most important is to know if this exposition to Zika virus has produced disease on her, because Zika virus can produce severe fetal malformation that even could require being the first trimester interruption of the pregnancy. So the most important here is to know if the woman has Zika or not. Yes or not? Yes.
Number 1, yes.
So now you obviously the psychological stuff and the teaching is not the most important, and the ultrasound is not the most important. The most important here, being the first trimester, is to know if the woman has been infected or not with the Zika virus. So you have 2 ways of knowing if the woman has symptoms that are not unique or exclusive of Zika, and the test of Zika. So which one is going to be best?
Number 1.
The test. So the best answer there is number 1. Yeah, is testing for Zika virus infection. The test comes positive, the woman need to decide abortion or not. The test comes negative, the woman can continue her pregnancy without concerns. Makes sense? So how I can, if I have this question in my Nclex, find the correct answer? I feel myself pregnant in the first trimester, okay? And I know that in pregnancy, when there are severe malformation, there is always an option of interruption of the pregnancy that, could be okay or not with me. So obviously, immediately my brain illuminates. Okay? The most important is to be sure if I got the virus or not, because I was exposed were cases of Zika virus and have mosquito biting me, but I am not sure if I have the infection. So 1 and 4 are the possibility, but which one is more precise? 1. So please, in Nclex, take time. Don't rush too much. Claro, no exagerating. Don't be procrastinator. But take your time in thinking, and always when you have doubts, so analyze all the options. Don't rush. Don't jump into conclusions. And when you have doubt, think that the client is your mama or your papa or your husband or your boyfriend or your whatever or your child, or think that yourself. And you see how your brain illuminates, then something comes, clarifies everything. The nurse notices that the healthcare provider omits hand hygiene after leaving a patient's hospital room. Which action by the nurse is the best at this time? Report to the infection control department, offer an alcohol-based hand sanitizing fluid, provide with a list, the doctor with a list of upcoming services on hand hygiene, remind the doctor about the importance of minimizing infection spread. What do you think is the best answer? What you do? So trying to see yourself.
Two.
Two.
I agree. 2 is the best option. So I see myself in this scenario. I see that el idiota este, okay, was touching a patient with MRSA and is leaving the room and is going to pass the MRSA to the next patient. What I do, I solve the problem. And no, this is not the moment to educate this doctor. It's the moment that, stop the dissemination infection. So the best that can be done is alcohol-based hand sanitizing, okay? In which disease cannot be used the alcohol-based hand sanitizing? That is
In
a
C.
common
difficile.
C. diff, Clostridium, C. diff, no hand sanitizer, no alcohol. Which of the following clients have a formal indication for a screening of hepatitis C carrier status? So you need to know that hepatitis C is a form of hepatitis in which the person can be a carrier of the virus. And it could produce chronic problems in the liver. So you need to know which kind of clients are the one that could be a carrier of hepatitis C and requires the testing. So a client who ate contaminated shellfish, yes or not?
No.
For what is important shellfish?
A. Hepatitis A.
Hepatitis A. So it is definitively a no. A client who received blood transfusion in 1992.
Yes.
Yes.
Sadly, before the 90s, the science didn't know that hepatitis C existed and was not investigated in transfusions. So many people receive transfusions with the virus of hepatitis C because was not investigated. And in those times, when somebody had hepatitis and were tested, we did the test for A, that was known, and B, that was known. But then both tests came negative. So we called this hepatitis, and I remember that hepatitis non-A, non-B. Was a non-A, non-B hepatitis. And I remember that this hepatitis was more frequent after transfusions. So I give you all the story to know that when a person receives transfusion before the 90s, when the hepatitis C was not screened in a transfusion, it is a risk factor. So if I receive a transfusion before the 90s, okay, I should be screened because maybe the transfusion had the virus. A client in long-term hemodialysis, yes or not?
Yes.
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 Yes. Sadly, even with all the precautions that could be taken, hemodialysis implies so much blood in the environment that hepatitis B and C are more frequent in patients receiving hemodialysis and nurses that work in hemodialysis than in other areas. So it's a yes. A client who injected IV drugs only once many years ago should be investigated?
Yes.
Of course. Once could be enough. Yes? So IV drug use is another risk for hepatitis C. A child born to a woman who is hepatitis C positive should be tested?
Yes.
Yes. It can transfer, can be passed through the placenta, the same as hepatitis B. Here, something missing here that I forgot when I transcribed because I was transcribing all those questions, but in clients in USA. Okay, so something missing here. And even is typo. An extensively tattooed client in USA.
Yes.
Okay, this question is a reproduction of an actual cellular applied Nclex question. And a student commented me some of those items, not all. I added the majority, all the risk factors for hepatitis C. So I created a question, but this specific item was in the question of the student. And it took me to make a research, okay, investigate. So I needed to look in the literature. In America, the tattoo parlors are controlled by the Department of Health, the health departments. So they are as controlled, visited, and and supervised as hospitals and nursing homes, etc. So the statistics says that tattoo in America is not a risk factor for blood-borne pathogens like hepatitis B, C, and HIV because the strict sanitary control that the tattoo parlors have in America. If you have the tattoo in, ¿cómo se llama? In Thailandia, in Thailand, or any other set, take care, okay? But in this case, it is an information that I bring to you because I did the research, I did investigation in the Center for Disease Control. The literature is there. There are investigations made about this. The tattoo climb, and now in America, everybody está tatuado, okay? O sea, cuando se pongan viejos y los tatuajes esos se empiezan a encoger, van a ver lo feo que se van a ver. Okay, so you remember, because I work a lot as LPN in nursing home. I saw a lot of old people with tattoo. Qué feo se ponen. Okay, so know that because it was in Nclex, and I did the research, and the research told me that no, tattoo, if it is in America, is not a risk factor. So a knowledge that I can share with you because I had to study, I had to investigate that when the question was presented to me. Which of the following cohorting of infection diseases is correct? So there are two clients in the same room, and you need to determine which one is correct. RSV with HIV, yes or not?
No.
No, because the RSV is going to be
It's
passed
contact.
to the HIV. Is contact, need to be alone. No. Client with anthrax pneumonia and client with active hepatitis C.
No.
Yes.
No. No.
No.
No. So which one is going to catch what?
Anthrax is gonna to catch hepatitis C.
No.
No, hepatitis C is standard.
Hepatitis C.
Hepatitis C is standard. You cannot get hepatitis C unless you have sex with this person or you receive blood as a needle stick or sharing needles, or maybe a French kiss if the person is bleeding in the gums. You understand? But you cannot get hepatitis C if you have a person in that bed and I am in this bed and we are not having sex. You understand what is a standard? That the patient is going to be in the same room, but in different beds. Yeah. And there are some diseases that, yes, are infectious. If you have sex with a patient with hepatitis C, you get the hepatitis C. If you exchange body fluids in any way with hepatitis C, you get hepatitis C. But two persons that are hospitalized in the same room, each one in his or her bed, don't need why to catch hepatitis C. The same applies for HIV and the same applies for hepatitis B. Am I reaching you with this message? Yes or not?
Yes.
It's important. And what you know about anthrax pneumonia is very contagious.
It's not.
Yes.
It's used as a terrorist, but it's not very contagious.
So anthrax is a standard precaution. And yo borré ya, yo cerré el file de... Ya, un segundito, señores. Ok, just a moment. A ver si lo tengo rapidito. Literature. Okay. Es más fácil. Just a moment, guys. It's just to convince you. I need to convince you. Okay, es más fácil que yo haga esto. And lo llame aquí. Okay, let's go to anthrax. So please remember that you have this resource, okay? So pulmonary anthrax is standard. No transmitted from person to person. So a person is in the next bed to me and has anthrax and cannot pass that to me. And let's see hepatitis. It's H, no? It's okay. No. Hace mucho. Yo. Sorry. M. Hepatitis, ¿cuál es? La C. Hepatitis C. Standard. Hepatitis C. Standard. Okay. They have some recommendation for hemodialysis center for the reason that we commented, but it's a standard.
So they can be together, Profe?
They can be together because the rule says if it is only standard, can be cohorted. The one that you cannot cohort are contact, droplets, airborne. Unless is verified the same infectious agent. And the only situation which is practical is the RSV. You can have several RSV cohorted in the same room. Okay? So it's important that you understand my message that said that for cohorting, only standard precautions alone can be cohorted. If there are different diseases and different bacteria, only if those diseases, those infectious diseases and bacteria or infectious agents are only standard, can be cohorted. When it is contact, droplets, and airborne, cannot be cohorted, except a practical approach, frequent situation, that is the bronchiolitis, because comes in epidemics and always is the same RSV. Okay, so based in this statement and knowing that anthrax is standard and hepatitis C is standard, yeah, we can cohort these two clients. This is one bed. This is another bed. They cannot pass the disease through the air. Yeah, but the RSV, because it's highly contagious and maybe the TV control or the, I don't know, the table, etc., can be touched by the HIV. The HIV cannot pass to the RSV, the HIV, unless they have sex or exchange of body fluid, which is not logical in the hospital. But the RSV, yes, can be passed to the HIV. That's why I don't want to put together HIV with RSV. RSV bronchiolitis virus can pass to the HIV. Okay, let's see the others, because all we need to eat all the options. Influenza, very contagious, and bronchiolitis, a different disease, can be together? No, because now you have bronchiolitis with influenza and influenza with bronchiolitis. You understand? No problem, ¿verdad? They pass through the air or contact, and no. Scarlet fever is droplet, and epiglottitis is droplet also, but they are different bacteria. The scarlet fever is an streptococcus. The epiglottitis is Haemophilus influenza B, the more common. So now you are going to have a scarlet fever with epiglottitis and epiglottitis with scarlet fever. Guys, I'm reaching you, or I'm very confused. I'm confusing you.
No, Profe, that's okay.
It's okay. because I'm afraid that sometimes I confuse you. Okay.
Okay, the bronchiolitis you said that was the epiglottitis, which is droplet or airborne.
The bronchiolitis
Bronchiolitis.
is contact.
Contact.
Tienen que
I always
aprenderse.
confuse, yeah.
Yes, I said that. ¿Dónde ponen ustedes las orejas cuando yo hablo, carajo? I said our logic says bronchiolitis. It should be through the air. But the science says it's not bronchiolitis, it's contact. And it brings confusion. And you need to take care. You need to control this tendency to confuse that. That's why I put here, watch, bronchiolitis is contact. Yes, watch, ten cuidado. Yeah, because yes, pero yo creo que ya now you won't forget. Yes or not? ¿Eh?
No, but the influenza is contact.
Cuando uno mete la pata, a veces, ya más nunca la vuelvo a meter.
Professor, can cohort a kid with bronchiolitis and influenza B? No?
Say again. If I can cohort.
Yes, a kid, one have epiglottitis and the other have influenza B.
You cannot cohort that.
No?
Mama, the epiglottitis is produced by Haemophilus influenza B, which is a bacteria. Haemophilus influenza B is not ¿cómo se llama? A virus, it's a bacteria. The Haemophilus influenza B is a bacteria. I know that says influenza, but has not only prójimo, has nothing to do with the influenza virus, which is the one that produces the flu. Haemophilus influenza B is a bacteria that is more frequent in children and is covered with this vaccine. HIV is Haemophilus influenza B. The Haemophilus influenza B produces pneumonia, produces meningitis, produces epiglottitis, are the three more common diseases in children produced by the Haemophilus influenza B. Has a vaccine intramuscular for our children, 4 doses. So when we have a child here in America, they are going to receive the vaccine against this bacteria to avoid pneumonia, meningitis, and epiglottitis related with that. Has nothing to do with the influenza. Influenza is a virus, okay, and has different diseases and different, okay, vaccine. Don't confuse Haemophilus influenza B con influenza virus. They're 2 different diseases and 2 different infectious agents. Clarified now?
Yes. I made the mistake.
Good.
What
Yes,
I
but
tried to say is if you can cohort the how is the name? Haemophilus influenza B with the bronchiolitis.
okay, you cannot.
Because
you
it's
cannot,
the same disease.
If you have bronchiolitis, you have a patient with bronchiolitis, a patient with pneumonia, for example, Haemophilus influenza B, then they are going to pass that because the bronchiolitis can be passed to this and the Haemophilus influenza can be passed to this. So now you cannot do that because
Okay. I thought the same disease.
the bronchiolitis is contact and is a virus called RSV. The Haemophilus influenza B is a bacteria and is droplet. So definitively no. So the rule is only infectious diseases that are only standard precaution can be cohorted. Memorizing all the diseases that are only standard is impossible. But the most common are the 3 famous: hepatitis B, hepatitis C, and HIV. But there are many others. There are many others. Maybe it's easier to memorize contact, droplets, and airborne diseases. So when I say bronchiolitis, okay, bronchiolitis, that I know that it is isolation, so cannot be cohorted. And when I say Haemophilus influenza B, that in this case is epiglottitis, requires isolation, so cannot be cohorted. So when the disease is a disease that needs isolation, cannot be placed with other person. What means isolation? Te vas solo pa'l cuarto. Means that you are going to be alone in the room. When they are talking about cohorting, are diseases that don't require isolation, even if they are infectious diseases. And the most famous infectious diseases that don't require isolate the client, hepatitis B, hepatitis C, HIV. But there are many others. I said now anthrax. I convinced you that anthrax is not a disease that requires isolation. It's a sole only standard precaution. So you can add anthrax. But let's go back. Simplify. Diseases that can be placed, two clients in the same room. Only diseases that are standard alone, that are not isolation. Isolation means that the patient needs to be isolated and need to be alone in the room. And if they must be alone in the room, cannot be placed with another client. Now it's easier for you to understand. So for that reason, try to learn the diseases, or at least the most common diseases that require isolation. So that's why I said it's a challenge for you to memorize this, because if those diseases are mentioned, require isolation. And isolation means the patient needs to be alone, cannot be placed with another client. So only diseases that are standard exclusively are the ones that can be cohorted. So okay, era esta, ¿no? Sí. So in this case, RSV require isolation? Yes, cannot be cohorted. Bronchiolitis must isolation? Yes, cannot be cohorted. Influenza must be isolated, cannot be cohorted. Sorry.
B?
Scarlet fever must be isolated, cannot be cohorted. Epiglottitis must isolation, cannot be cohorted. Anthrax needs isolation? No, because I need to learn that anthrax is a standard, doesn't need isolation. And hepatitis C needs isolation? No, because I need to learn that hepatitis C is a standard, doesn't need isolation. Now you understand how you are going to manage this situation?
Yes.
Okay. The clients admitted with presumptive diagnosis of bacterial meningitis. After initiating droplet precaution, so you initiated droplet precaution with meningitis, bacterial meningitis droplet. Which doctor order should the nurse carry out first? Now the question is difficult. It's a chronological prioritization. Administer cephalosporin IV, the treatment of meningitis cephalosporin. Initiate an IV catheter that is needed to give the antibiotics. Prepare the client for lumbar tap. Initiate seizure precaution. What is done first?
Lumbar tap.
Lumbar tap, yes. I agree with you. Guys, you need to accept that the best answer there is C, prepare the client for lumbar tap. Why? Because in meningitis, after initiating droplet precaution to stop the dissemination of the disease, the priority is to give the antibiotic, because what can improve, save, cure the meningitis is the antibiotics. Of course, to give the antibiotic, you need an IV. So before giving the antibiotic, you need to make an IV. But before initiating antibiotic, you need to obtain the specimen of the liquid that allows the culture and sensitivity. So it is a rule. If it is an infectious disease, the disease must be cultured. The specimen where the disease is present should be cultured to verify the bacteria that is producing the disease and how it behaves with the antibiotics, so the sensitivity. So the priority before initiating antibiotics is to do the culture. How the culture is done? The culture is done through lumbar tap. The specimen is obtained through lumbar tap. The seizure precautions are important, but are a precaution of a risk diagnosis, which is not a priority. So the patient could have seizures or not. And if the patient has seizures, then you need to have the oxygen, the suction machine, the lorazepam prescribed at hand, etc., etc. So seizure precautions are important, but not the first. The first is to lumbar tap, get the vein, initiate antibiotics, move the client to the room, and start seizure precautions in the room. Do you understand the rationale? Summarizing, don't forget that you need to obtain the specimen before initiating antibiotics. And this is the example of question that you now are going to deal with that. A client with 35 weeks gestation came to labor room with membrane rupture of 18 hours. Okay, it's those infections, diseases applied to OB. The baby is viable. The baby at 35 weeks can survive. And the woman had probably a premature rupture of the membranes because the baby is premature, is not a term. And when the membranes rupture before the 38 weeks of gestation, it's called premature rupture of membranes. Remember that these membranes is the separation between a sterile environment, which is the uterine cavity, and a vagina that have a normal flora, have a flora that is normal, but should not go to the interior of the vagina. So, to the interior of the vagina. Okay, so now you understand the meaning of the rupture of the membranes and what has to do with infection control. The test for group B Streptococcus in vagina is not known yet. The Streptococcus B or Streptococcus agalactiae, to be more precise, is the most common bacteria infecting the endometrium or the uterine cavity in those situations. Which of the following intervention has the highest, so now a prioritization question, highest priority? It means that everything is a priority, but one has the highest priority. Which of the following nursing interventions has the highest priority? Assess for uterus contraction, initiate prophylactic antibiotics, avoid vaginal digital examination, practice a deep stick urine analysis. What do you think from the point of view of nursing, because it's a nursing question, is the highest priority for the nurse?
Start the prophylactic antibiotics.
B.
Avoid vaginal digital examination.
Okay,
Avoid
so,
vaginal digital examination.
so we are obviously between B and C. Okay, B and C. So why is yes is correct? Why is true that the protocol says don't do vaginal digital examination? Why?
Because you can introduce the flora that is in the vagina through the
here you have the anus, here you have a perineum, here the vagina, and when you do that, you are introducing the normal flora of this area deeper word now is open the door. Yes, so vaginal examination is prescribed, is avoided when the membranes are broken. Doctors prefer to use a speculum, a sterile speculum, to open the vagina and just see moving the fingers to the wound here. Yeah, so it is true, and it's also true that, you know, beginning in this moment, generally they initiate antibiotics. So now, from the point of view of nursing, what is more important, to avoid introducing bacteria or initiate prophylactic antibiotics?
We cannot decide the antibiotic treatment. It should be the
No,
healthcare.
don't use this criteria. Don't, please. This is an important intervention. Don't use this criteria in Nclex. Nclex says in the document that they publish, and you can access in their page, that if a medication is an alternative, you must assume in Nclex that the medication has been prescribed. So if the antibiotics could be initiated, because it has been already prescribed. The issue here is to decide which is more important, prevent or treat.
Prevent.
The prevention, the antibiotic prophylaxis.
Okay, so antibiotic prophylaxis is to treat, okay, the bacteria, is to kill the bacteria. In reality, the prevention is not introducing bacteria in the vagina.
Yes, but you're doing prevention to avoid infection when the baby passes for the birth canal. That's the objective for the prophylactic antibiotic. Avoid infection from the baby.
O sea, if you have a surgery, you will not take care anymore of the asepsis, and because the patient could be ordered antibiotics. Is the same reasoning, I think. If I have a surgery, I'm a surgeon and I'm doing surgery, I don't care a lot if the scalpel is not really sterile, because the patient is receiving prophylactic antibiotics, and the prophylactic antibiotics are going to prevent infection. It is the way that it works?
No.
Prophylactic antibiotics are demonstrated that decrease the incidence of severe infections, endometritis, and not the neonatal sepsis cannot be prevented in this way, but at least the endometritis in the woman, okay, in the case of premature rupture of membranes, okay, when they have more than 18 hours of duration. But what is more important? Not introducing the bacteria or not using a contaminated scalpel, or using antibiotics?
In this case, I think it's the use of the prophylactic antibiotic.
Okay. Well, I les dejo esa pregunta. So trying to, this is an actual English question. The same discussion appears each time they present these questions. And so we don't know what is the answer key in the English.
Sí, okay, professor. But
it's
gonna be C the answer?
No, we don't have the answer to this question. We don't have an answer key. This is not a test that I can write. This is Nclex. I don't have the answer keys of the Nclex. Do you know that? Are you getting the idea? Are you understanding that I don't have the answer keys of questions that have been okay in Nclex? Do you understand that?
Professor,
Yeah.
but what do you
Do you understand that?
Yes, we do.
You understand that?
Yes.
Are you
Yes.
understanding? Because
Yes.
I need to be sure that you are understanding.
But what do you think?
I already presented me that I have a I am a surgeon. If I am a surgeon, I take a lot of care of sterility. No matter that the patient could be receiving prophylactic antibiotics. I cannot depend on the prophylactic antibiotics.
Sí. Can.
This is my opinion, but there are a lot of people that are very convinced because that what I've been observed that is more important giving the antibiotics than to prevent the infection.
Professor, I saw that question in your work. And
I don't care where you saw the question. Here, the problem is what we think. You know, what is more important? Okay,
when we do
to kill the bacteria or avoid the bacteria from entering in the uterus.
Avoid. I think avoid the bacteria is more important.
So it's something that you need to decide because this was sadly or happily a real situation in Nclex. We don't know what is the answer.
They also use the antibiotic prophylaxis for prevention to avoid the infection in the neonatal, in the newborn. That's why I saw this question in another similar situations, and the answer was they always was prophylactic antibiotic, and the reason was for that.
Okay. So no problem. So go ahead. Choose this.
In the book says first avoid vaginal examination and then after administer antibiotics in the book.
Okay. So if you saw that in your world and your world for you is the Bible, because Bible, I'm Christian, and for me Bible is accepted as it is written. Even sometimes I don't agree too much, but I accept the Bible, you know. But it's different my religion with the practice medicine. Okay, if you accept your world as the Bible, okay, it is something that is you know, that is enough for you. But I just left you thinking. It's just thinking. But suppose have the possibility, because you did Kaplan, you did Hesse, and you discovered that Hesse Kaplan had mistakes. I don't know if you did Hesse or Kaplan, because if you did Hesse and Kaplan, you need to know that they had mistakes. Okay? And I just suggest you that take care with the question that I know is in your world. I know how you present in your world, but the question is also in Nclex. And I just make you think what you should be deciding to answer in the test because it's interesting. Okay, I leave this question to study. Okay, to study. So to decide what should be the best option.
No, Professor, please. You already said that you think that is C, no?
No, I don't think anything. I just, you know, object that I agree that prophylactic antibiotic is a standard of practice.
Professor, excuse me, I have a doubt about this question. A lot of doubt is not with B and C, it's with 8. Because they say a client with 35-week gestation come to labor room with membrane rupture of 18 hours. After 24 hours, that fetus gonna start to suffer.
Why?
Or
why?
Could be a meconium, could be an infection.
And then the problem is the infection. The suffering is the reason for infection.
The patient go to the labor room. I don't know if initiate the prophylaxis or assess the uterine contraction.
What do you do with assessing the uterine contraction?
I need to know if the patient is in labor or if we need to induce the labor, because after that I would take the prophylaxis.
You think that there's a priority to induce labor? Because the patient is going to enter in labor in any moment.
Or it's in labor already because
since it's a fact, since a moment that membranes rupture, the patient cannot be avoided to go in labor. The baby is going to born. This labor cannot be avoided.
Will be immediately or not. I don't know. I need to know. I need to know if will be right now or in 30 minutes. And after that, I will do whatever they want to do with the antibiotic, or we avoid the digital examination.
Yeah, but you present the labor. You present the labor like something that is a very abrupt, very rapid, or something that the labor is something very precipitous.
No, exactly.
This is another opinion. Okay, so another opinion to discuss, to study this question. So another reason to study the question. Very good.
Yeah, I'm in doubt with that,
Okay, so what you need to do when you have doubt, go to the book.
Search.
Investigate.
But sometimes not even the book have the answer, because sometimes when you look at the book, there is so hard to find the answer.
Okay,
like,
so now this is one of the stuff that you need to learn, to read books and to find the answer, because I know that you have been, not frequently using the books. So now to elevate your level as a professional, you need to start, using the book. So we were left in question to study and find the answer, and bring that in the next way that we discuss. Okay, but you think about this. Okay.
Doctor, but you are a doctor. You know in real life what is done first, right?
Okay. Well, doctors sometimes, commit mistakes. Okay.
So
well, guys, thank you for your attention. See you.
Thank you.
Next time. Bye.
Thank you, Professor.
Bye.
Thank you.
Thank you, Professor.
Thank you, Professor.
Bye-bye.
Thank you, Professor.